Good evening, everyone. Welcome to the second night of the PSRC 2021 Pentathlon. Tonight's program will focus on nerve and hand and will be co-moderated by Ted Kung and Amy Moore. I first want to welcome Greg Borchell, PSRC Chair, to give us a few words of welcome.
Thanks, Allison, and welcome to everyone. Welcome to event 2 in the pentathlon, hand and nerve. So if you love hand and you love nerve, you're in the right place. Obviously, it's really unfortunate we can't all be together like we ordinarily would be at the PSRC annual meeting. Soon, we will be able to get back together, see our old friends, make new friends. It's going to be great. But tonight, you know, the 250 people that registered for this event, I think are living testament that the spirit of plastic surgery research is more than alive and well. It is strong, and we're going to get through this. It's going to be awesome. We have people coming from different countries, even from Germany, where it's like 20 o'clock or something like that in the morning. It's great. So I'm going to turn it back over to Allison. Thank you all for tuning in.
Wonderful. Thanks, Greg. We're very excited for tonight's programming, but first, a few nuts and bolts. We want to thank our wonderful roster of presenters and faculty for their participation. We couldn't do this without you. And we also want to thank our generous sponsor of tonight's program, Synovus MCA. Synovus's support of the PSRC has been significant over the last year and has helped the Research Council to be able to put on our educational programs and foster a community of engaged future leaders in the field of plastic surgery research. So thank you, Synovus MCA. We will hear from Synovus MCA later on in the program, and we encourage everyone to be engaged for this portion of the evening. Before night 2 of the PSRC Pentathlon begins, here are a few rules and regulations for tonight. Please stay on mute out of respect for our speakers. Please be sure to have your camera off while the speakers are presenting. You can turn on your camera for the Q&A portions. Please participate in the Q&A sessions through the chat function. We want to hear your questions. The PSRC Mentorship Committee is facilitating a breakout room, Meet Program Directors, Getting into Residency with mentors Brian Drolet, Sam Lin, and Nicole Summer. Throughout the Quick Shots session, which begins around 7:35 p.m. Eastern Time, please take advantage of this opportunity to meet with these leaders in our field and to ask them questions and get their advice. Please plan to join us for subsequent nights of the Pentathlon. Event 3, tomorrow, June 9th, craniofacial and congenital anomalies. Event 4, Thursday, June 10th, transplant and microsurgery. And Event 5, to complete the Pentathlon on Friday, June 11th, breast, aesthetic, and gender affirmation. Be sure to follow PSRC on social media and join us as a member. The Research Council is the preeminent research organization in plastic surgery, and there is so much innovation and high quality science that comes from our community. For those who aren't members yet, we would love to have you involved. I would now like to turn this over to our other co-moderator for tonight's evening, Ted Kung and Amy Moore.
Hi, good evening, everyone. We're really excited to be here with you. I'm happy to introduce our first speaker. Sami Tufaha is one of my good friends and a superstar nerve surgeon and surgeon scientist. He comes to us from Johns Hopkins School of Medicine in Baltimore. We have asked him to speak about Of Mice and Men, Understanding and Overcoming the Limitations of Animal Research in Nerve Surgery. I'm really excited to have you here, Sami. I know you're going to blow it away. And I think you're on, can we see you yet? Oh, and there you are. Looks like you're coming straight out of the OR. So look at you.
Thanks for the invitation, and appreciate the introduction. Great seeing you. So the kind of introduction, we're going to be hearing about some really exciting research coming out of the laboratory throughout this program. So I wanted to start by taking a step back and considering animal research in nerve surgery more generally. I'm going to talk about some of the limitations that we face and how we continue to push the field forward. Here are my disclosures. When we consider what we know or what we think we know about nerve surgery, I think it would be an understatement to say that animal research makes up the large foundation of our knowledge base. it shouldn't be surprising that our understanding of the underlying physiology of nerve regeneration comes from animal research. This is true for pretty much all the disciplines within medicine. But I think what's more peculiar and noteworthy is that in nerve surgery, many of the surgical approaches and techniques and treatment algorithms that we use are exclusively derived from animal research. And the same is true for devices and therapeutics. You may find it surprising to know that most of the nerve wraps and conduits that we're currently using clinically have never undergone formal clinical testing for efficacy. And I think we're all painfully aware that we still don't have any therapeutics that have made it all the way through clinical trials. I think our over-reliance on animal research largely arises from from the inherent difficulties that we face in performing high-quality clinical research in nerve surgery. Different types of nerve injuries manifest very differently, and this makes it hard to compile well-powered clinical data sets. And we still don't have any really solid clinical outcome measures that we can hang our hats on. And I think it goes without saying that well-controlled clinical trials in nerve surgery are still essentially non-existent. So given our dependence on animal research in nerve surgery, and specifically on small animal research, I think it's important that we ask ourselves, how much can we trust this data? And if we're honest with ourselves, I think we have to acknowledge that the small animal models that we use are imperfect approximations for the clinical realities that we're hoping to learn about. So to avoid a situation in which we're being misled, we have to first understand the intrinsic limitations of the animal models that we're using so that we can begin to interpret them more thoughtfully. We also have to recognize that there are major flaws in the way that we're performing animal research that can and should be remedied. And lastly, I'll discuss how we can add meaning and purpose to our animal research by placing more emphasis on performing large animal studies and on clinical trials. So there are intrinsic differences between humans and rodents, and while this is somewhat of an oversimplification, I think it's fair to say that the physiologic processes tend to progress faster in rodents, and the physical dimensions to which they occur tend to be shrunk down. As an example of how the physiologic processes progress faster in rats, let's consider the deleterious effects of chronic denervation. So in rats, if you wait 3 months to repair a nerve after injury, you can expect approximately 40% of the amount of motor functional recovery as you would see in an acute repair. And if you wait 6 months, the motor function that's recovered essentially bottoms out. Now, clinically, we know that we can repair a nerve in a delayed fashion 6 months after injury while still expecting a reasonable chance of achieving meaningful functional recovery. As an example of how the physical dimensions tend to be scaled down in rodents, let's consider the nerve allograft. So there are many different studies in rats showing that nerve allografts greater than 3 centimeters cannot support regeneration. Now, this is not meant to make any comparative statements between allografts and autografts. I do believe that autografts have inherent regenerative benefits, but we also have a growing clinical experience with the allografts that suggests that, at least in some situations, they can be used at lengths greater than 3 centimeters successfully. Here's a patient of Steve Moran's who sustained a blast injury to the lower extremity. He presented with complete foot drop, and on exploration, the distal stump of the deep perineal nerve was completely obliterated. So he performed direct neurotization of the tibialis anterior with a 7 centimeter allograft. And you can see here that the patient recovered good dorsiflexion and fairly normal gait. So this is an extreme example, probably an outlier, but the point here is that a 7 centimeter allograft in a rat would fail every single time. And I don't think it's all that controversial to say that it's possible that 1 centimeter in a rat doesn't equal 1 centimeter in a human when you consider that the entire length of the sciatic nerve in a rat is just a few centimeters long. So I think we also have to recognize that there are serious flaws in the way that we're performing our animal research, and this isn't just specific to nerve research. There was a survey performed by Nature a couple years ago that brought attention to a number of different factors that lead to what they call the reproducibility crisis. And these factors include pressure to publish, lack of oversight and blinding, selective reporting and publishing of data, manipulation of statistics. And in order to address all these issues, it's going to add substantial cost, it's going to slow down our productivity, but it's absolutely necessary in order for us to produce data that we can believe in. There are some methodologic issues more specific to nerve research that I just want to briefly touch on. I think there's a tendency to overemphasize misleading outcome measures, sometimes take them in isolation to suggest efficacy. For example, the number of axons on a nerve cross-section doesn't necessarily correspond to meaningful nerve regeneration. And this is because of sprouting and pruning. And more generally, I think we need to begin defining a primary outcome measure before a study begins and really hanging our hat on this primary outcome measure when we're trying to define efficacy. And this is what we do in clinical trials. And doing so is going to help us avoid the tendency to cherry pick the positive findings after the fact. I think most would agree that this primary outcome measure should measure functional recovery. The problem, though, is that measuring functional recovery in our rodent models is notoriously difficult. All of the behavioral assays suffer from inherent behavioral variability, which affects the reliability of these tests. Isometric tetanic force testing has more recently emerged, and it's extremely reliable. The issue here is that it can only be performed once at the time of sacrifice because you have to disinsert the tendon. And it also requires some specialized equipment and training and expertise, which can also limit adoption. So to address some of these issues, we developed a new method for measuring functional recovery. It essentially blends Dr. Bertelli's grasping test with isometric tetanic force testing. And so we anesthetize the animal, and then we percutaneously stimulate the median nerve to induce maximal tetanic contraction of the finger flexors. And then we can measure force load to failure in the animal's grasp. And so we found that the reliability of this test is roughly equal to isometric tetanic force testing, but it has the additional benefit of allowing for serial in vivo measurements so that you can chart functional recovery over time. We hope this is a step in the right direction. I do think there are opportunities to use large animal studies and clinical studies to add meaning to our small animal research. For ethical reasons, cost considerations, practicality, large animal studies will not and should not replace small animal research. But I do think that large animal studies and clinical studies, for that matter, can be thoughtfully employed to identify correlations in outcomes with our small animal models to thereby derive conversion factors, if you will. Wouldn't it be nice if we had a rough equation where we could say that X centimeter graft length in a rat times a given conversion factor equals Y centimeters in a human? And on a deeper level, the translational research that we're currently performing in the field of nerve surgery does feel like a dead end. There have been countless studies showing that X, Y, and Z improves nerve regeneration in rats, but we still haven't successfully completed a single randomized double-blind placebo-controlled clinical trial. And so it's time that we begin moving promising interventions and therapeutics from the lab to clinical trials. Doing so is going to add purpose to our translational research, and it's going to help us really move the field forward. Along those lines, we've been using a non-human primate model that makes use of stimulated grip strength testing, which I mentioned earlier in rats. And we found this to be very reliable and fairly straightforward to use. And we're currently using this model to test a drug delivery system that we hope to then move to clinical testing. This is just one example of how I think our field is making progress and is moving closer to the finish line. Now, clinical trials represent the final mountain that we still have to conquer. In Baltimore, we're currently enrolling patients in a phase 2 randomized double-blind and placebo-controlled clinical trial. And this experience has made me painfully aware of the many challenges and obstacles that make this such a daunting task. Beyond the regulatory hurdles and the costs, there are tremendous challenges in powering this type of study, because you have to find patients who have the same nerve injured at the same level, repaired the same way, in order to be comparing apples to apples. And I think the solution here is that we need to create clinical research networks, clinical trial networks, so that we can pool our resources and start to conquer these challenges together. And we also need to work to establish a single outcome measure that we're all comfortable using as our primary outcome measure. And still many challenges, but I do think that a number of groups are making progress on this front. So to end on an optimistic note, I do believe we're collectively making progress, and there's reason to believe that there are some major breakthroughs on the horizon. And I'll end by thanking my tremendous team. Thank you.
Fantastic. Thank you, Sammy. I think we have a couple of minutes. We could take 1 to 2 questions if there are any for Dr. Tufaha. It's a great way to open the evening, sort of looking at where we are and the challenges we need to overcome, which this type of society is the best way to do that, putting a lot of great minds together, and a lot of innovation comes from the PSRC. It's a beautiful talk, Sammy. Thank you.
Thanks so much. I appreciate the invitation and looking forward to the rest of the program.
Well, since we have so many people asking questions, please don't be shy. I do have a question for you, Sammy. So again, I love this talk. I remember seeing a version of it in Paris, and I think that you capture the struggles we have in science with nerve. And also the clinical trials. I too am feeling that regulatory hurdle that's taken months just to get a multi-center trial off the ground. So it is what we're facing. My question for you is what you brought up about the conversion factor. And now that you're doing non-human primates, and do you think that if we created a study that we'd be able to try to figure out that conversion study? Like what is needed? Like if we really dug into that?
Yeah, thanks for the question. I think it's very doable. I think what we would have to do is basically pick a few fundamental questions that we're really interested in tackling, and then essentially create a very similar model, let's say median nerve cut and repair above the elbow in both rats and then in non-human primates. And then we can follow them out and then see, kind of track the outcomes that we care about, and then see how we can correlate them. Maybe we'll say, all right, we get 50% recovery at 6 months in the primates, but we see 50% recovery at 3 months in the rats, or something along those lines. And then, probably wouldn't be quite as clean and straightforward as I'm making it seem, but at least it would give us some way to, meaningfully interpret our rat data. I think ultimately we need to focus on the small animal studies for practicality, ethics, but it would be nice to kind of be able to frame the findings better so that we can make use of them, especially given how hard it is to do good clinical studies. I think we really are counting on the rat studies, and so we need to get the most out of them.
Totally agree. Well said. Thank you. There's a question from Dr. Borchell. What do you think might be the main biological reasons for, or might be the main biological reasons for the discrepancy between rat and human?
Some of the general trends that I was talking about with things being sped up and shrunk down in rats, those are just my opinions and observations, so don't take that as being gospel. But when you think about it, the whole rat's life is about 2 years. And any of us who have done rat studies, we watch them go through puberty and then age and die, through the course of a single 1-year research fellowship. So, I think intuitively, if I was going to guess, that seems like a good place to start, to say that maybe, 1 year or 1 month in a rat equals more than 1 month in a human. And then I started to notice that in terms of the progression of the innervation atrophy in these rats. I think it happens much quicker. And so, I don't understand the underlying mechanisms, and I couldn't give you a very nuanced explanation, but those are just my general observations, and I think it's based on observation and intuition.
Great. Well, thank you again, Dr. Tafaha. We really appreciate your contribution to the evening. And now I'd like to introduce our next speaker. It gives me great pleasure to introduce Jack O'Neill. Jack is an athlete and Paralympic hopeful. When he was first born, doctors told his parents he would never live a normal life because of the severe congenital defects throughout his body. After a childhood filled with surgeries, Jack elected to amputate his leg at the age of 9. Jack and his family would never have imagined the opportunities that would transpire. He was soon identified as an emerging disabled athlete in both swimming and triathlon. Jack has spent the last 9 years traveling and competing in both able-bodied and elite para competitions while trailblazing opportunities for himself and other youth athletes with a disability. Jack is a committed Division I college swimmer and also is pursuing a spot on the Team USA Paralympic team. As a driven athlete, Jack is fiercely committed to training and competing while also advocating for inclusion and equal opportunity for disabled athletes. Jack just recently graduated from high school. He is 18 years old and he was named by the Colorado Springs Gazette as one of the best and brightest of the class of 2021. And we are so glad that he was able to fit us into his busy schedule. He just gave his valedictorian speech last week, and we're excited to hear from you tonight, Jack, on overcoming a diagnosis through sport. Thank you so much.
Hi, my name is Jack O'Neill, and I'm 18 years old. I want to say thank you for having me here today. I'm very excited to share my story and hopefully inspire you all in both your personal lives and even your medical practices. Today, I'm going to share with you the medical details of my life, but I really hope to show you the human side of overcoming a diagnosis and finding my life's purpose because of medical challenges I faced at a young age. One thing I hope to express tonight is that my story was made possible by my doctors and medical team working with me and my parents to make decisions that would allow me to pursue an unconventional goal of being an elite athlete with a disability. I was born 18 years ago with a complicated set of birth defects. I was born in a large teaching hospital, and a team of doctors, residents, and medical students told my parents that I would never live a normal life. Of greatest concern was the defects in my spine. I have congenital scoliosis caused by hemivertebrae. There are 2 curves in my spine, both roughly 45 degrees. I have fused ribs, sacral agenesis, and a fusiform kidney. I also was born with a club foot, dislocated hips, and a VSD. I had my first surgery when I was 6 weeks old. It was an Achilles tendon release, club foot casting, and a closed hip reduction. When I was 6 months old, I had an open reduction in my hip and spent 3 months in a full body cast. My spine was always the biggest worry, but it remained relatively stable as I grew. I spent the first few years of my life in various casts and braces for my hip and foot, and shoe lifts to accommodate a leg length discrepancy. When I was 6 years old, the discrepancy was 6.5 centimeters, and my shoe lifts were becoming so tall that they weren't functional. At this point, I had caught up developmentally, and I was walking, climbing, riding a bike with training wheels, and in school. At the end of my kindergarten year, I underwent a procedure to lengthen the tibia and the fibula in my left leg. The bones were surgically broken, and an external Ilizarov fixator was attached to the broken bones with rods and pins. For 55 days, my parents turned the 8 rods, which pulled the broken bones 1 millimeter, forcing the bones to grow. The pain was physically and emotionally excruciating. I also struggled with infections at the insertion sites for months. It was the first time in my life that my parents felt like I was disabled, and even though the procedure was intended to make my life easier, it was a major setback developmentally. At one of my appointments, my surgeon sank down in a chair and said, "I cannot believe I'm putting a 6-year-old through this." She then suggested that I spend time in a chlorinated swimming pool, because that was really the only activity that was safe for me to do. I started doing aquatherapy at the pool, and I quickly fell in love with the freedom my body felt when I was in the water. Months passed and the fixator was taken off. Physically, I started to heal and my parents put me on a summer swim team. My first season as a swimmer, I was disqualified in every single event that I competed in. The coach of the team didn't see the value of teaching me, a kid with a disability, the rules of swimming. At the end of the summer, he told my parents that there are special programs for kids like me at the Park District. My parents knew he was wrong, and we found a swim coach that saw my true potential, and she taught me how to swim. And the next summer, I won every event that I competed in and began to establish my place in youth swimming. That was the start of my pursuit of competitive sports and my family's campaign for inclusion of kids with disabilities in youth sports. Over the next couple of years, I moved on to a more competitive swim team. I loved swimming, I loved school, and I was settling into a normal life. While everything was going well, the difference in my legs was becoming too much to ignore, and we knew I would need to go through another surgical leg lengthening. It felt like it had taken years to get past the emotional trauma of the first one, and the thought of going through it again was terrifying. Over the next few months, we consulted with doctors all over the country and eventually came to the decision to amputate my leg. I was 9 years old, and after a childhood filled with surgeries, therapies, and orthotics, we realized my leg was never going to function normally, and it was holding me back from the things that I wanted to do, especially as an athlete. As you can imagine, reaching that decision did not come easily. My doctors trusted my parents' intuition and agreed to take the risk and go the very unconventional route of amputating my leg. 1 month before my 10th birthday, I underwent the operation. That night, as I was in a hospital bed screaming in pain and confusion, as my parents helplessly questioned their decision. My recovery was pretty typical for an amputation, meaning it was difficult. I struggled with physical pain and mysterious phantom pain, and it's safe to say we were not prepared for the emotional side of recovering from a limb loss. Slowly, day by day, things got easier, and 4 weeks after my operation, I went back to swimming. Once I was in the pool, everything started to fall into place. I was back competing within 8 weeks of my operation, and the opportunities to pursue sport as a para-athlete really took off for me. 4 months after my amputation, I was introduced to the sport of triathlon. As a swimmer, the challenge of adding cycling and running to a race was intriguing. I began competing in triathlons when I was 10 years old, and I continued to pursue swimming competitively and was able to successfully juggle training and competing in both swimming and triathlon throughout high school. Triathlon as a sport sets the standard for inclusion, and I was fortunate to be recognized as an emerging para-triathlete at a young age. While triathlon has given me a platform to advocate for inclusion and to showcase what a disabled athlete is really capable of, my true passion is swimming, where I've grown up as the only disabled athlete on my team and at almost every competition. I've qualified for championship meets under able-bodied time standards while also competing at elite Paralympic meets, and I'm currently training for the Tokyo Paralympic swim trials in 2 weeks. But what I'm most excited about is to be a committed Division I swimmer, as I will be attending the University of Wyoming in the fall, where I will study journalism. I'm honored to be one of the first disabled collegiate athletes, and I really hope to create progress for other athletes at the NCAA level. Anyone who is an athlete knows that sports give back what you put into it. Physically, it has always been natural for me to pour myself into training and competing. Emotionally and mentally, it can be tough being the only athlete with a disability on a team or at a competition. I've had coaches who didn't want to coach me, and I've had race directors who didn't want me at the race. Advocating for inclusion is not always easy because sometimes I really just want to be like everybody else and train and race. But I recognize the sport has given me a platform. And while I'm laser focused on my personal goals, opportunities to inspire other people present themselves. I truly believe that in order for me to reach my goals to become a Paralympic swimmer, I need to train and compete against able-bodied swimmers. And in doing that, if I inspire my teammates and competitors to do their best, it proves that the inclusion of disabled athletes benefits everybody. And if I have to fight for this inclusion and fight to create opportunities for myself, I'm willing to do it. And I'm going to do it in a way that leaves the door open for athletes with disabilities that will follow me. I hope today that I left an impression on you that will carry on to your personal life, maybe as an athlete or as a parent of an athlete. I also really hope in your professional career that someday a patient with a complicated diagnosis and what seems like impossible dreams comes into your office and you think of me. I truly believe that the capability of people is limitless, and I know that my success is a result of a family and a team of doctors and therapists that chose to believe in a little kid that just wanted to swim.
Jack, that was incredible. Thank you so much for sharing your story and your wisdom beyond your years with us. I think you summarized a lot of interactions with others that you've had throughout your life and what you've learned from those. But what do you think is the best message that you could give to a bunch of surgeons who are listening with you tonight?
Yeah, for sure. I would say for you guys, your impact can be beyond just what you see in that person, whether that's an operation or an appointment or something like that. I know I have surgeons that I've kept in touch with through like I've mailed graduation cards to, and people that I still keep in touch with and genuinely care about where I'm at in my life. And I know that without those people and without that like extra support and investment from them, that I would not be where I am today. So I would definitely say there's some special people that you'll come across in your field, and it's good to invest in those people.
Well said. Are there any other questions for Jack?
Jack, I have a question for you. Thank you so much for speaking at our Nerve in Hand section. Your story is so incredible, and I mean, it's just amazing. I have a second question that follows Allison's question. You know, we're surgeons, and we see a lot of people with congenital things or with trauma, and sometimes I'm at a loss of words when people are kind of at their lowest point. You know, whether they're an adult or a kid. You know, when I'm sitting there in front of them, trying to encourage them to take that next step. Do you have any advice for me on how to encourage my patients, whether they be kids or adults? Because it's really hard, and sometimes I just feel like I'm not really saying the right things. You know, I don't know what they need to hear so that I can help them.
Yeah, absolutely. I think that's a great question. I know for me, it was about finding an outlet in a community of people. I have a great swim team. I have a great triathlon team, and I have a great group of other people who are amputees and a variety of disabilities who are all invested in sports and things that I'm invested into. And so to have those group of people to like fall back on, and especially like as I was going through my amputation, that was the biggest thing. Is my world really changed when I met Melissa Stockwell, my now triathlon coach, and someone who has done so much in my life for me. So I would say definitely tell people to put themselves out there, get themselves into a group of like a community of whatever interests them. And for me, that was sports, and I'm very thankful for the people that I've come across.
Thank you so much. And thank you also to Allison for introducing us to Jack O'Neill. This was amazing. Thank you again, Jack. You're awesome. Very, very inspiring. So I'd like to see if anyone else has any more questions for Jack. It's a very special opportunity to ask him questions. I think, Jack, everyone just wants to say thank you. And we really just appreciate you being here. You know, usually we just, have a scientific meeting, but it's awesome to hear your story. It's very inspiring. Thank you very much.
Yeah, thank you guys so much for having me.
So I want to now move on to the next portion of our evening, which is where we're going to hear from the presenters from our top scored abstracts that were submitted this year. And our first paper is entitled Eye Tracking Analysis as a Means of Evaluating Aesthetic Result Following Toe-to-Thumb Transfers, a Pilot Study. And this will be presented by Nathan Hebel from Mayo Clinic in Rochester.
Hello, my name is Nathan Hebel. I am a medical student at the Mayo Clinic Alix School of Medicine, and I'll be presenting our findings on the use of eye tracking technology in our toe-to-thumb transfer patients. The authors have no disclosures, and all information has met HIPAA and IRB authorization. So to begin with a brief overview, our team set out to assess the efficacy of eye tracking technology as a way to objectively analyze post-operative outcomes in our toe-to-thumb transfer patients. Of course, is not limited just to toe-to-thumb, but any hand surgery really, when you want to look at the aesthetic result and how people perceive the post-operative outcome. The way we did this is we had blinded participants come in and examine images of our patients, 26 images exactly. While they were doing this, eye tracking technology was following their gaze and mapping it on the image to where they were looking, but for also how long. To no surprise, the reconstructed thumb was of greatest attention for the participants, and there were two locations on the thumb exactly, or the toe to thumb exactly, that were of most importance, and we'll get to that later and how that is implicated in future outlook. So we'd like to see maybe a modification of the surgical technique as a way to mitigate some of these focal areas. As well, it would be important to include some of these focal areas with pre-surgical counseling, just so that patients understand the way that their surgery will be perceived, because we know that there's fantastic functional results, but aesthetic results are also important to patients, and we'd like to see that be more incorporated in the counseling process. So to begin, we had 13 toe-to-thumb transfer patients, and what we did was we had pictures taken of them in both a dorsal and palmar orientation. Those images were taken here at the hospital. They were done professionally to ensure consistency. And then from that, we took those images and showed them to the 40 blinded participants. These participants looked at each image for 6 seconds and were told to analyze the images for symmetry between the hands, if there's anything different. And while they were doing this, the eye tracking software was following their gaze, and like I said, was creating a heat map to show the location of where they were looking, as well as for how long. What we discovered was that between the two hands, the reconstructed thumb was viewed 63% longer than the control thumb on the contralateral hand. This is, again, no surprise. We would understand that the reconstruction would draw more attention, and that's what we would like to help mitigate in the future. Within the ipsilateral hand, the reconstructed thumb was viewed almost the same amount of time as the rest of the hand. So it was 50% of the time examining it was spent looking at that reconstructed thumb, relative to the 30% roughly of the control hand, showing that it is drawing significant attention. We can see here in figure 3, there are 2 red circles on the images showing the key locations that the heat maps discovered were areas of attention. So this included abnormal nail beds, as well as the junction of the native hand skin with the toe skin, whether that be the scar area or just the differences in the skin tone and texture and such. Here we have a representative image. You can see that the darker the green means not quite as much focal area, and then the brighter the yellow means much more focus. And we can see here that there is significant focus on the abnormal nail bed of the reconstructed thumb on the right side of the image. The reason why this is important is similar to what I had said before. Knowing that the abnormal nail bed and the junction of the 2 different skins as areas of focus, it would be really important to examine different surgical techniques as a way to help mitigate some of these issues in helping to improve the aesthetic outcome, so that maybe the reconstruction isn't quite so obvious. We know that toe-to-thumb transfers have fantastic functional results, and we'd love to see the aesthetic results kind of match that as well. Of course, this is not limited just to toe-to-thumb transfers. We'd love to see this technology implicated in evaluating the aesthetic outcome for many hand surgeries, so that those functional results and the aesthetic results are both being improved for patients. And I guess in moving forward, there are, like, those 2 areas are of importance, and we would like to see that incorporated into the counseling of patients, just because the functional results are important, but the aesthetic results are just as important for many patients, and knowing which areas of their reconstruction may be attention drawing areas may be important for them, for whether or not they have the surgery or what they might behave afterwards with the surgery. Thank you so much for listening.
Great, thank you, Dr. Habel. We're going to hold our questions till after the 3 papers. Our next paper is sensor motor myoelectric control using surface-based regenerative peripheral nerve interface, or RPNI. This will be presented by Amir Deydashtian from University of Michigan in Ann Arbor, Michigan. Thanks.
Hello, thank you for this opportunity to present our study. My name is Amir Deydashtian, and I'm a research fellow at the University of Michigan. The human hand is a delicate instrument that enables us to explore fine details and interact with our environment. For those living with upper limb loss, the ability to perform activities of daily living and quality of life are significantly impacted. Current advanced prosthetic devices can provide fine motor movements with multiple degrees of freedom, and also be equipped with surface sensors to extract tactile force. However, Their clinical application has been limited so far, and only 2 to 5% of patients are currently using these devices. The problem is that for the patients to utilize these devices, a bidirectional nerve-machine interface is required to enable simultaneous and independent motor and sensory signals transmission, a paradigm which is currently not available. Our work with Regenerative Peripheral Nerve Interface, or RPNI, has shown its reliability in intuitive motor control of the prosthetics. The RPNI construct is composed of a transected peripheral nerve implanted into a free muscle graft. The muscle graft subsequently becomes reinnervated and revascularized and can amplify small microvolt nerve signals to significantly larger millivolt muscle signals. However, the capture of myoelectric signals depends on indwelling electrodes that are cost prohibitive, and their use is currently not commercially approved. Moreover, the RPNI is not primarily designed for providing somatosensory feedback. Without tactile or proprioceptive feedback, patients need to rely on their other senses that can lead to mental fatigue and device abandonment. It is already known that the denervated skin produces molecular and biochemical cues that attracts growing sensory axons to reinnervate the sensory organelles. This physiologic concept has also been suggested in patients received targeted muscle reinnervation or TMR surgery. Therefore, to eliminate the need for indwelling electrodes and simultaneously complement RPNIs with sensory end organ targets, we investigated the placement of RPNIs underneath the defatted skin in rats. We anticipated that motor axons will preferentially reinnervate the muscle, while sensory axons reinnervate the skin component of superficially placed RPNI or sRPNI. The purpose of current study was to investigate the viability and signal transduction capabilities of superficial regenerative peripheral nerve interface. To create sRPNI, the contralateral EDL muscle was harvested. Ipsilateral tibial nerve was transected distally in the thigh and was implanted into the EDL muscle graft. Then the fabricated RPNI was placed and secured in between the primary incision of the biceps femoris muscle. Overlying skin was defatted, and to avoid undesired movement, the skin was secured around the sRPNI construct using interrupted simple buried sutures. All RPNI constructs were allowed to mature for 2 months before conducting endpoint testing. Functional sensory and motor reinnervation was examined using electrophysiologic testing. First, the overlying skin was lightly brushed using cotton swabs that generated afferent neuronal signals in the proximal tibial nerve. Since the tibial nerve innervates the posterolateral legs and plantar surface of the paw in normal rats, mechanical stimulation of lateral thigh will not produce afferent signals under normal conditions. Similarly, stretching the skin generated synchronized and monomorphic afferent signals. To further confirm the skin's reinnervation by the tibial nerve, we stimulated the skin electrically and recorded classic three-phasic sensory nerve action potentials, or SNAPs, in the proximal tibial nerve. Electrical stimulation of the tibial nerve resulted in visible sRPNI muscle contraction and generation of robust, readily recordable compound muscle action potentials, or CMAPs, through the surface electrodes. Following the dissection, we observed nerve fibers that were originating from the sRPNI constructs and reaching the skin dermis. To confirm this observation, we performed immunohistochemistry using anti-neurofilament antibody, which is general nerve marker, and anti-choline acetyltransferase antibody, which is specific for motor fibers. Well-defined network of neural fibers in the dermis was observed. Remarkably, these fibers were positive for neurofilament 200 and negative for choline acetyltransferase, suggesting preferential migration of sensory axons into the end target sensory organelles present in the dermis. Using the whole mount immunolabeling of the solvent-cleared muscle component, we were able to visualize numerous sensory axons traveling through the muscle and arborizing motor axons with new neuromuscular junctions that were identified using alpha-bungarotoxin specific marker against the nicotinic acetylcholine receptors. To summarize, we showed that the superficial RPNIs remained viable in the subcutaneous space and regenerated effectively to produce compound muscle action potentials that were recordable through the surface electrodes under skin. Physiologic separation of the sensory and motor axons was demonstrated using electrophysiology and immunohistochemistry. Taken together, the superficial RPNI could be a simple alternative to transmit simultaneous, real-time, and independent sensory and motor signals between the residual nerve and the prosthesis. Thank you for listening, and I'll be happy to answer any question regarding our study.
Thank you, Dr. Dedashtian. Thomas Harris from Johns Hopkins in Baltimore will be presenting the next paper entitled IGF-1 Hydrogel-Based Nanofiber Drug Delivery System to Improve Nerve Regeneration and Functional Recovery After Peripheral Nerve Repair.
Good evening, everyone. My name is Tom Harris, and I'm a postdoc in Dr. Tafaha's lab at Johns Hopkins. Thank you very much for the opportunity to present IGF-1 Hydrogel-Based Nanofiber Drug Delivery System to improve nerve regeneration and functional recovery after peripheral nerve repair. There are no disclosures. Peripheral nerve injuries are common and often result in poor functional outcomes. And despite advances in surgical techniques, there are a lack of therapeutic agents to address this. Augmentation of the growth hormone axis carries promise for treatment of PNIs. Growth hormone is released from the pituitary gland in response to gonadotrophin-releasing hormone from the hypothalamus. And growth hormone acts on the liver, which results in release of IGF-1, which directly acts upon multiple tissues throughout the body, including neurons, myocytes, and Schwann cells. Growth hormone has previously been tested in translational models and was found to improve nerve regeneration, minimize denervation-induced muscle atrophy, and improve functional recovery. Although growth hormone helped improve functional outcomes, its use clinically is limited with the need for daily parenteral dosing and the associated systemic toxicities. The solution to this is using IGF-1, the primary effector of the growth hormone axis. However, IGF-1 is limited by its short half-life. And so to address this challenge, our group previously developed a delivery system to provide local release of IGF-1 by encapsulating IGF-1 within biodegradable nanoparticles. Nanoparticles are made using a two-step process using polyelectrolyte complexation to increase the loading capacity of IGF-1, and then secondly, by flash nanoprecipitation to encapsulate these complexes within biodegradable nanoparticles. These IGF-1 nanoparticles were applied to a chronic denervation model, and similar to growth hormone, the IGF-1 nanoparticles reduced muscle atrophy and increased functional recovery. However, although in vitro release kinetics demonstrated release of IGF-1 for 6 weeks in vivo, animals had to be injected every 2 weeks to maintain a response. So with this in mind, the aim of this study was to design a drug delivery system for IGF-1 using a nanofiber hydrogel carrier to maintain the nanoparticles at target tissue sites for the duration of drug release. This was applied to an in vivo chronic denervation model, firstly to evaluate its efficacy on functional outcomes, axonal regeneration, and neuromuscular junction reinnervation. Secondly, to assess whether there is a dose response. And thirdly, to investigate the delivery system in a non-human primate PNI model. The composite is made using electrospun PCL nanofibers bonded to hyaluronic acid in a hydrogel network. And on the right, the composite increased expression of the anti-inflammatory cytokine markers TGF-beta and interleukin-10, which allows for gradual remodeling and replacement of the composite with vascularized tissue. As a carrier for IGF-1 nanoparticles in vitro, the composite provided sustained release of IGF-1 for over 50 days, as highlighted here in red. The IGF-1 drug delivery system was tested using a chronic denervation model in rodents. The median nerve is denervated for 12 weeks and then repaired using an ulnar to median nerve transfer. And in the illustration on the left, experimental animals were injected with IGF-1 at the time of denervation and then 6 weekly thereafter. Negative controls were injected with the drug delivery system without IGF-1. In addition, 3 doses of IGF-1 were tested to determine if there was a dose response. And during the regeneration period, all animals underwent weekly functional assessment. This was assessed using stimulated grip strength testing, shown here in the video on the left. The median nerve is stimulated to induce maximal tetanic contraction of forearm flexors. A handle that sits in the rodent's paw is connected to a force meter, which is distracted, and the maximum force generated is recorded. The graph on the right represents functional recovery with time after nerve repair in weeks on the x-axis and grip strength measured in newtons on the y-axis. The negative control group are represented with the gray line, and the high, low, and intermediate doses of IGF-1 are represented in the red, blue, and orange lines, and all three groups exhibited significantly increased functional recovery compared to untreated controls, which equated to about 35%. However, there was no difference in functional recovery between the three doses of IGF-1. The IGF-1 drug delivery system effectively reduced muscle atrophy. Myofiber cross-sectional area is represented in the graph here on the left, with negative controls on the left of the x-axis and positive controls on the right, and the three doses of IGF-1 are in between. And on the right of the slide, we have representative images of myofibers stained with laminin. And all three doses of IGF-1 treated animals resulted in significantly decreased muscle atrophy compared to untreated controls. When assessing the percent reinnervation of neuromuscular junctions, it was a similar story, as all three doses of IGF-1 treated animals demonstrated a significantly increased percentage of reinnervated neuromuscular junctions compared to untreated controls. On the right, these are longitudinal images of neuromuscular junctions within the FDS, and untreated controls are shown in image A and B at the top, and IGF-1 treated animals are shown in C and D on the bottom. The drug delivery system was then investigated in a non-human primate model using 2 adult male rhesus macaques. The median nerve was transected and immediately repaired in the midbrachium. One animal was treated with the IGF-1 drug delivery system, which was injected along the median nerve, distal to the repair site, as well as into the anterior compartment of the forearm. The other animal was treated with normal saline as a control. A 6-weekly injection schedule was used, and release kinetics were assessed using enzyme-linked immunosorbent assay to quantify the concentration of IGF-1 within target muscle. In the graph on the left, biopsies of FCR were collected every 2 weeks for the first 12 weeks. And the IGF-1 treated animal, which is represented with the blue line, demonstrated sustained linear release of IGF-1. And the 2 images on the right were taken at the time of harvest and show the composite, which is indicated with the yellow arrow in our target muscles, FDS and FDP. On the left of this slide, ultrasound guidance was used to locate the median nerve for stimulated grip strength testing to assess functional recovery, which is shown here in the video in the bottom left. The graph on the right outlines the percentage of functional recovery compared to baseline. And the IGF-1 treated non-human primate demonstrated a 31% increase in functional recovery after 70 weeks compared to the untreated control. This novel drug delivery system provides sustained release of bioactive IGF-1 for 6 weeks. It enhanced functional recovery in both rodents and the non-human primate to between 30 and 35%. Elements of this drug delivery system are already FDA approved. Therefore, the next step to clinical translation will be to perform a well-powered primate study before progressing to phase 1 clinical trials. I'd like to thank Chen-Hu Chiu and Kareem Sahain in particular for their help with the study, as well as Dr. Tafaha for his support and mentorship. Thank you.
Thank you, Dr. Harris. If the last 3 presenters would please turn on their cameras, I'd like to open this up now for everyone for questions and answers. And also another reminder to use the chat feature to ask your questions.
Yes, I would like to applaud all of our speakers tonight. What great presentations, and it makes me so proud to be a nerve surgeon to see what you all are doing. So congratulations to you all. There is one question so far, don't be shy, and it's for Dr. Harris. How long after denervation could the hydrogel be used?
So in the rat model that we used, the animals underwent a period of 12 weeks of denervation. And then during the denervation period, to minimize muscle atrophy, they are injected every 6 weeks. So in terms of after denervation, I think in terms of a traumatic injury where there's that period where you let everything settle, I think in the study we did, I don't have an answer for that one, but certainly what we're looking at more is how we can minimize the muscle atrophy, as that's certainly what's limiting functional recovery.
Now there's so many questions here. It's going so fast. So let me bring it up. It looks like Dr. Snyder-Warwick, you have a question. Would you want to say it? That'd be
I'd
great.
love to.
So I can keep up. Sorry.
This is a question for Dr. Hebel. Just wondering if there's any evidence for patient-reported outcomes showing a similar finding. So, you know, are patients noticing that people are focusing on the reconstructed thumb? Is Dr. Hebel here?
I
Do not believe Dr. Hebel is here.
Maybe we'll move on to the next question.
Well, and I have a question for Dr. Dadashtian. So congratulations on all of that work with regards to your multiple outcome metrics for immunohistochemistry and such. Did you, by chance, because we always care about this, did you assess any pain in these animals, or did you think that you could find, I know from outcomes, were any of those used to assess sensory, such as painful stimulation?
Thank you, Dr. Moore. This is a really great question. We did not, but based on the current evidence that this happens all the time, even for the incisions, after any surgeries, that area is a bit numb, and after a while it may become a little bit hypersensitive, but by the time it will become normal again. So we don't anticipate that terminal axonal sprouting cause any pain, but that's a great thing. We actually want to investigate this more in future.
Great. I could just imagine the scenario of trying to use it for a prosthetic, but then having a sequela of it being painful, and then they don't put the prosthetic on for the other reasons. But let's hope that's not the case. And we go from there. So lots of questions for you, Dr. Harris. So, you know, buck up, here we go. But we're going to just start with one that, again, that's pulled up right here is, how do you explain the significant results after 70 weeks when IGF-1 delivery is detected only up to 6 weeks?
So for that, we injected the animal every 6 weeks. So from our dosing, from our in vitro analysis, that it was between about 6 to 8, 9 week was the optimal window. And so we played it on the safe side and went for a 6-week re-injection schedule. And that was in the non-human primate ultrasound guided. And with our serial biopsies of FCR, median nerve innervated, but not affecting our functional recovery outcome measure, that again showed sustained release. So I hope that answers the question.
Great. And then I'm going to follow up on that because it sounds like there's interest. How are you controlling the release kinetics for sustained release?
Yeah, so I see that there are a couple of questions, and I'll try and answer them both in the same run. So first, if we go back to the formulation, so we have a high and a low viscosity injection. So that high viscosity is essentially, if you think of toothpaste along the nerve distal to the repair site, and then the low viscosity is injected into the median nerve innervated muscle, and then it stays in that anterior compartment and it just diffuses nicely, so it's low viscosity. And then in terms of, I think there was another question with regards to systemic injection or toxicity, that we use that ELISA to measure the concentration of IGF-1 in our target tissue, so in the FTP, FDS muscle, and then in the nerve. And then we also took serum.
Do you want to say?
Sorry.
Is this empty? Let's see here. Oh no, there are people.
So we took serum measurements from the heart at the time of sacrifice, and then compared the ratio with our local IGF-1 concentration, and we found that to be an acceptable non-toxic. And we've got our non-human primate toxicology pending as we harvested those a couple of weeks ago. So be excited to share those with you once we get those results.
Really exciting. Whenever we move towards this non-human primate, doesn't diminish all the other work that's done. I think we all get this like, wow, it's exactly what we need to see, but we also become a bit more critical. So thank you for answering in such a great way. And thank you to all of our speakers. I think in the interest of time, I think we should continue on our great programming.
All right, great job, speakers. I'd like to introduce our next paper, Peripheral Nerves Engage in Reciprocal Neuro and Angiogenic Crosstalk with SMCs and Extremity Trauma, presented by Charles Huang from Harvard in Boston.
Hello, everyone. Thank you for the opportunity to share our group's work here at PSRC. My name is Charles Huang, a Harvard Plastic Surgery resident, and I am excited to share some of our exciting findings from the Levy Lab regarding the crosstalk between neuro and angiogenic signals. I have nothing to disclose. Heterotopic ossification, or HO, is a debilitating formation of bone and soft tissue, usually in the context of an acute musculoskeletal trauma. You can see here in these panels multiple foci of bone formation in areas where they definitively don't belong. In addition to the limitation in mobility and joint function that you could imagine from this ectopic rigid bone, this pathology also leads to impairments with wound healing and significantly impairs the patient's quality of life. As a means of illustration, this gentleman is a patient who developed HO in his elbow after a burn injury. HO lesions like this are typically hypervascular and also have a proclivity for growing around nerves, causing severe pain. In fact, pain is a central feature of HO. And given this duality between vascularity and nerves that we encounter again and again in the clinical setting, it led us to wonder to what role might nerves and vessels together play in the genesis of HO. So in order to emulate the human disease, we look to our reliable and reproducible mouse injury model, where we perform a partial thickness burn on the dorsum of the mouse and also a concomitant Achilles tenotomy to simulate a musculoskeletal polytrauma. This incites a cascade of inflammation, chondrogenesis, and ultimately mature ectopic bone, as you can see in orange here. Using this model, we took a look at the natural course of the injury site after the inductive injury. Here we saw increasing density of nerves and vessels after the initial surgery. Nerves are labeled here in green with TUB3 or beta tubulin, and vessels are labeled here in red with CD31. And indeed, in these graphs, you can see after the injury itself, you can see an increasing, stepwise increase in the density of nerves and vessel ingrowth into the injury site. As I've touched on before, we knew HO was intensely vascular, and as you can see here, this is corroborated with our injection molds of an injured mouse. We previously had shown that mesenchymal progenitor cells marked with PGFR alpha would be bringing in VEGF-A to the injury site, which is a pro-androgenic signal. And when this was selectively knocked out with these VEGF Flox PRX1 Cree mice, we found that that would directly inhibit the formation of HO. So naturally, we anticipated that knocking out a provascular signal like VEGF-A would inhibit the formation of CD31 positive vessels. And this is indeed exactly what we saw. However, surprisingly, with the exact same perturbation, we also saw a reduction in TUB3 positive nerves. And given this seemingly double duty of this vascular signal, we wondered what would happen if we preferred the converse experiment. Would inhibition of neural signaling possibly, just possibly, behave similarly to what we saw when limiting vascular signaling? So we went back to the mouse model and it also introduced a sciatic nerve injury to the initial inductive injury to inhibit neural transduction. And lo and behold, we observed the identical phenomenon, a decrease in nerves, vasculature, and bone. In order to gain a little more granularity, we examined our HO site with single-cell RNA sequencing, yielding cellular populations, including macrophages, neutrophils, lymphocytes, and other inflammation, cutaneous cells, muscle cells, nerves, fibroblasts, and vascular or perivascular cells. And what we found when we looked into the endothelium and smooth muscle cells is that the neurectomy or an inhibition of neural signal transduction led to a shift in the phenotype of these varied cells. Utilizing gene modular scoring, as you can see here on the right, we observed that in a neurectomized mouse, that these vascular and perivascular cells had reduced proliferation, terminal differentiation, and activity along the VEGF provascular pathway. For a more translational application, we reinforce this data with selective molecular blockade of TRAC-A, which is the receptor for the neurotrophin nerve growth factor. So thereby producing a molecular inhibition of neural signaling. And doing this also led to a similar finding where we saw an attenuation of nerves, vessels, and bone formation. To further characterize the transcription profile of nerves, we examined a single nuclear RNA sequencing dataset that examined dorsal root ganglia from mice who had been subjected to similar sciatic nerve injuries as ours. And this yielded two distinct populations. The non-neuronal support cells of the stroma, including glia and Schwann cells, and the actual subtypes of neurons contiguous to the peripheral nerve, continuous with the peripheral nerves that we are investigating at the injury site. Focusing on the neuronal subpopulations, we observed high expression of TRAC-A or NTRK1. But more surprisingly, again, we had across domain strong expression of a vascular signal, VEGF-A, in neural tissue. Further stratifying by specific types of neurons, we see that the TRAC-A expressing neurons highlighted here in cluster 1, again, strongly upregulate the vascular signals. Our immunofluorescence data only corroborated this finding, that nerves, while indeed are repositories of the propagation of neural signals, they are also simultaneously repositories for vascular signals. Here, as you can see with this positive staining for VEGF-A from dorsal root ganglia of a mouse after burn tenotomy. So what does this all mean? In the context of HO, we're actually growing more excited about this day by day because this highlights a strategy for non-opioid analgesia. In fact, anti-nerve growth factor antibodies are under clinical trials for mitigation of pain in select musculoskeletal diseases. And with this crosstalk that we have highlighted today, we may be attenuating HO just as a bystander effect due to this crosstalk. This vascularization is important and is a necessary condition for bone maturation. Furthermore, this might open up an array of new tools in the clinical management and treatment of aberrant wounds. Flipping this exactly 180 degrees, we can conversely, in the field of wound healing, strive to stimulate nerves in order to facilitate vascular ingrowth that would thereby accelerate healing. And then for a variety of different applications in other fields, namely those that are reliant on vascular and neural regulation, such as oncology, might stand to benefit from some of the fine-tuning targets that we are identifying in our studies. And with that, I would like to thank Dr. Levy and those from our group and collaborators that contributed to this project and our funding sources. I would gladly accept any comments and happy to answer any questions at the end of the segment. Thank you.
Great, excellent talk, Dr. Huang. Now, next will be Abigail Myers from Cleveland Clinic in Cleveland, Ohio, and she'll be presenting our next paper, which is metacarpal subsidence following trapeziectomy.
Hi, everyone. My name is Abigail, and I'm very grateful for the opportunity to present our study, Metacarpal Subsidence Following Trapeziectomy. There are no conflicts of interest to disclose. It is controversial whether subsidence after trapeziectomy prognosticates pain, poor outcomes, and a need for revision. So the aim of this study was to investigate the degree of subsidence following trapeziectomy and whether subsidence contributes to poor outcomes. An IRB-approved retrospective review of all patients who underwent trapeziectomy for osteoarthritis of the first carpal metacarpal joint was conducted from 2003 to 2019. Patients with available radiographic imaging greater than 3 months postoperatively were included. Patients with arthritis of the metacarpal phalangeal joint of the thumb, arthritis of the radiocarpal, distal radial ulnar, and midcarpal joints were excluded. Demographic information, pain scores, and revision procedures were recorded. Connolly-Rath patient function scores were determined for outcomes. Subsidence was measured by the ratio of the difference between the trapezial space preoperatively and postoperatively divided by the trapezial space preoperatively. In the right figure, you can see that we measured the trapezial space from the base of the thumb metacarpal to the scaphoid, and then we standardized this measurement to the length of the capitate. Patients were then divided as having a high degree of subsidence, which was greater than or equal to 50%, or a low degree of subsidence, which was less than 50%. Demographic information, pain scores, Connolly-Rath scores, and revision procedures were recorded and compared between the two groups. Pain was compared using a Mann-Whitney U test, and age was compared using unpaired t-tests. There were a total of 186 patients who underwent 211 primary trapeziectomies. The average age at the time of surgery was 61 years, with a range from 18 to 86, and 85% of patients were female. The average follow-up was 38.2 plus or minus 31.9 months, with a range from 3 to 146.5 months. Metacarpal subsidence was present in all patients after trapeziectomy, with an average of 58 plus or minus 20.8%. And there was no significant difference in age, pre-op, or post-op pain between patients with high and low subsidence. 68% of patients had high subsidence, which was greater than or equal to 50%. The average age of this group was 60 plus or minus 10.6 years. The age ranged from 18 to 86 years, and 80.9% of them were female. Pain decreased significantly from 6 with an interquartile range from 5 to 8 to 1 with an interquartile range from 0 to 2 after surgery. And based on Connolly-RASS scores, 25.7% had good outcomes, 48.7% fair, and 25.7% poor outcomes. 32% of patients had low subsidence, with an average of 34.6 plus or minus 12.1% in this group. The average age was 61 plus or minus 8.7 years, and there was a range from 37 to 84 years in this group. 87.4% of this group were female. Pain also decreased significantly in this group from 7 with an interquartile range from 6 to 9 to 0 with an interquartile range from 0 to 3. And there were 8.9% good, 33.9% fair, and 57.1% poor outcomes. Overall, there were a total of 7 revisions in 5 patients with an overall revision rate of 3.3%. There was 1 male and 4 female patients. All of them were right-handed, and the right hand was revised in 3 cases, while the left hand was revised in 4 cases. 2 of the revisions were on a single thumb from the same person. Overall, the average subsidence prior to revision in this group was 76.7 plus or minus 24%, with a range from 33% to 100%. In 4 cases, the subsidence decreased after revision, so the trapezial space increased. The subsidence decreased from 72 plus or minus 28% to 56.9 plus or minus 0.1%. The subsidence actually increased after revision in 1 of the patients from 59.2% to 70.2%, and it remained 100% subsided in 2 of the cases. So the metacarpal was touching the scaphoid. And the revision procedures included 1 CMC capsulodesis, 1 had an MCP arthrodesis involved. There were 3 total tightrope suspensionoplasties, and 2 had tensor fascia lata allografts, but 1 had it ultimately removed along with a palmar fasciotomy in their second revision. And that same patient had a scaphoid pull placed in their first revision, which was ultimately removed in the second revision. 3 of the patients had good outcomes, 1 fair, and 3 poor outcomes after revision surgery. Overall, post-trapeziectomy, pain scores improved significantly in patients with both high and low subsidence post-trapeziectomy. Subsidence occurred in all patients, and it is rare that subsidence is symptomatic and requires revision. Thank you very much.
Thank you, Dr. Myers.
Now like to have the last 3 presenters turn on their cameras and open this up for Q&A. Ted, take it away.
Thank you. Thanks, everyone. Great talks. I encourage everyone to ask questions. Right now, we have 1 question in the chat, and it's for Dr. Huang. So let me ask that one first. So could you remind us about the timing of injury during which you saw differences in the endothelial cell phenotypes? And have you looked at the EC phenotypic changes over time?
Absolutely. Thank you for that question. So part of our transcriptomic experiment involved the investigation of several time points. The data set that we showed examined day 3, 7, and 42. The snapshot that we showed in the presentation was for 7 days. And from what we saw in the single cell, there was a difference in tip cell phenotype that corroborates some of the in vitro work that we've done, where we would actually spike conditioned medium with nerve cultured cells, and with that stimulus, we were able to actually demonstrate an increased migration of endothelial cells using several perturbations, including a scratch test. On top of all this, we are doing additional immunofluorescence and spatial transcriptomics to kind of further reinforce this idea, but our preliminary data set does look like they are concordant.
Do you think some of those differences relate more to growth factors, or do you think it's more related to migration, proliferation, those kind of things?
I think the short answer is probably both. The beauty of and the sheer overwhelming feature of transcriptomics is that it gives us so much resolution. And so what we're seeing is that in addition to some of the phenotypical experiments that we historically have relied upon, we're actually able to delineate, even at the single cell level, what spectrum of transcriptomic profile there exists within any given perturbation in the system. So, well, part of that examination, one of the tools that we use is trajectory analysis, to the most common and canonical one being to the Monocle package. And that's actually ongoing investigation to see exactly what degree of variability there is within these endothelial cells. My hunch is that there is going to be a very wide spectrum, but the tall order will be to actually specifically come up with discrete time points or discrete transition states of these endothelial cells. And that's the type that's really, I think, what part of the novelty that we're really excited about diving further into.
Well done. Congratulations.
I have a question, Jacques, for Dr. Myers. So congratulations on your study and looking at, over 200 patients who've had CMC, arthroplasty, and trapeziectomy, I should say. And what I think is great and profound about it, so I have a comment and a question really, but is that you showed decrease in pain. I find patients who I see in my clinic with subsidence that they more suffer from lack of strength. And so when you had written down, and I'm sorry I missed it, about poor outcomes versus good outcomes, was that what was taken into account for that poor or good outcome, or was pinch strength specifically looked at?
Thank you very much for the comment and the question. Yes, it's a great question. We actually used the Connolly-Rath scoring system, which is based on a paper written by Connolly and Rath. And the score was based on pain after surgery for that. So a good outcome indicated no pain, a fair outcome indicated moderate pain, and a poor outcome indicated a lot of pain. So we use that there, but then we also understood that strength is more of an issue with pinch strength and grip strength in these patients because the tendon is the only thing suspending the metacarpal. So in that case, we actually continued the study and we started to look at the temporal evolution of subsidence over time, and then also the differences in grip strength, if there were any, and pinch strength between patients with high and low subsidence. And it turned out in the further studies that there was no difference found in the grip and pinch strength in the high and low subsidence groups. But of course, all patients who undergo trapeziectomy do suffer from that decrease in pinch and grip strength. It just wasn't significantly different between the two subsidence groups, if that makes sense. Does that answer your question?
It does perfectly. Thank you. Surprising.
Yeah, so I have a follow-up question for Dr. Myers, actually. And also, I'm from Cleveland too, so it's nice to see your background with the Cleveland Clinic. So my question is that, so in your study, if you show that, given that pain, it wasn't really different for the high or low subsidence patients, and then I think you had just said that even pinch and grip strength wasn't that different either. How should we treat subsidence as an outcome measure when we're looking to study these patients, when we're looking to see which technique is better for trapeziectomy? Should we even be using it as a major outcome at all?
Thank you for another great question. So based on this and like the further things we've looked at, the index pinch, like all the palmar abduction, radial abduction, all the grip strengths, and the pain, it seems like this might not be clinically significant at all when you have higher or lower subsidence. This is just based on our group of patients that we have right now in this retrospective review. And that's actually something we bring up in the discussion is why are, like, I guess, you know, people who are comparing techniques tend to use subsidence as a way to say that one technique is superior to another. But we actually didn't find a difference in median subsidence between FCR, APL, and like palmaris longus just tendon use. So even if there was a difference, it might not even be clinically significant, and it might be better to use pain or some other concrete clinical outcome rather than subsidence to say one technique is superior to another. Thank you. Does that help?
Thank you.
Great.
So we have a couple more minutes, and I have a question here in the chat room. It's for Dr. Huang. It says, I'm curious if you all tried using other dimensionality reduction techniques, such as SPADE and /time cluster, that take the temporal dimension into account to elucidate the temporal changes.
That's actually a great question. One that we are really, that's the next step of our analysis, actually. We did not specifically use SPADE. One of the drawbacks that at least I'm personally aware of with SPADE is that it doesn't inherently, the program itself doesn't inherently provide you a mechanism to directly produce direct comparisons, at least statistically. But the means that we're actually pursuing this is by, like I mentioned before, the pseudo-time analysis through Monocle, but additionally, we're also performing concurrently spatial transcriptomics across time points to actually even see what at the protein level, what exactly is going on. And to further elucidate this at the transcriptomic level, we can utilize our ATAC-seq, which we have actually implemented in some of our other projects, to really identify the open reading frames that give us an ability to at least infer what kind of gene programs are beginning and at what times, and temporally how they relate to one another. So that's a very astute question, and actually the real big thing to tackle for us next.
Excellent. I have a comment and a question for Dr. Nigan. So thank you very much for your great study. And I give a shout out to Grant Kleiber, who is a good friend and a previous fellow of mine. So I know you talked about as your limitations, the difference in who's submitting and putting in these nerve blocks. Is that also, and maybe I missed this, what is the solution of the medication? Is there changes and differences among that as well? And did you find that using 0.5% Marcaine or that was evidence of any kinds of change in your analysis?
Thank you for your question, Dr. Moore. And it's always a pleasure to be on with you and learn from your wise ways. And thanks to everybody who's on. So for the most part, they used ropivacaine as the block when anesthesia had done their peripheral nerve blocks. I'm trying to remember off the top of my head. We'd have to just follow up to see exactly if there were any sort of other anesthetic solutions, but it was mainly, oh, sorry, that's for the one-time nerve blocks that were used separately. I would have to look into that. For the most part, I think it ended up being actually may have been ropivacaine, but let me follow up on that. The interesting thing is for the TMR only patients, they only received Exparel on their own. So there was actually a local anesthetic that was provided at the time of the TMR only patients.
That's great. I mean, I think that was sort of my question of why, because I don't know, but if you're checking when you're getting your morphine equivalents, that it may matter, right, as they're post-operative, and I would try to check that out. So great, good job.
Thank you.
Thank you. And I actually have another question for Dr. Nigan. It's a very fascinating paper. I was just curious, knowing how TMR works to alleviate pain, what do you think is the mechanism of your suggestion that TMR may work immediately? Because if it's that immediate, is there enough time for reinnervation to happen? to occupy those growing axons?
Yes, this is something that, it's hard because like can a nerve that's just had surgery be susceptible and provide less pain stimulus, even in the absence of a nerve block? And the possible mechanisms for this may be, okay, is there a chemical signal that the distal motor nerve and that you're connecting to is providing? That's definitely possible. Is it down regulating the sensitivity to inflammatory markers? And the immediate period, I mean, this is immediate postoperative. This is the first few days after the actual surgery, the amputation has happened. So that would be the hypothesis. But again, the limitation here was that there was a high correlation between the TMR and the fact that there are patients that receive TMR and nerve blocks. So it's interesting to say, oh, this is just due to TMR, but it's interesting that even with this many patients, over 200, that there is a suggestion that TMR on its own had an effect.
Thank you. Thank you, everyone.
All right. Well, we are a few minutes ahead of schedule, but that's great because we will now be transitioning to our quick shot presentations in this room. The mentorship breakout room, however, will also be going on. And so this is the program that's Meet the Program Directors and Getting into Residency. So that I'm sure is going to be great too. Those mentors are Brian Jolet, Sam Lin, and Nicole Sommer. So that is going to be opening up now as well. And so you can click on the breakout room pop-up and click join. Otherwise, stay with us for the quick shots. I'm going to just give you guys a few minutes to make your decisions.
And again, everyone, if you do not see a pop-up, you should see a breakout button at the bottom of your page or 3 dots with the word more, and you should see break under that.
Great, Pete. Thank you. I'm watching our participants and it hasn't dropped down yet. So I'm going to, oh, there we go. Okay, well, you have that option to jump in, but we're going to keep moving in the meantime with our quick shots. So our first quick shot presentation is the peripheral nerve influence on soft tissue sarcoma progression. This will be presented by Michael Davitt from Stanford University in Stanford, California.
My name is Michael Davitt, and today I'll be discussing peripheral nerve influence on soft tissue sarcoma progression. I have no disclosures. For a little background, there have been a number of recent investigations into the interactions between visceral solid tumors and the autonomic nervous system that have demonstrated positive feedback loops which encourage tumor growth and neural invasion. However, there's been little interrogation of peripheral somatic neuron involvement in solid tumor progression or in sarcoma nerve crosstalk. There is significant heterogeneity in nerve tumor signaling across different tissue types, and this highlights the importance of clarifying the relevant molecular signaling pathways that are specific to somatic nerves and peripheral sarcoma interactions, which could point towards new potential therapeutic targets. For this study, murine fibrosarcoma cells were transfected with Firefly luciferase GFP lentivirus, and this was injected into mouse hind limbs either before or after sciatic neurectomy or sham surgery, creating 4 groups. Weekly tumor measurements were taken using in vitro imaging systems, or IVIS, and after 4 weeks of growth, tumors were collected, weighed, and compared to the unaffected hind limb. At early time points, the groups receiving surgery prior to tumor implantation measured smaller under examination by IVIS. However, by about 2 weeks after tumor implantation, this relationship reverses. We found that sciatic neurectomy after intramuscular sarcoma cell implantation resulted in slower tumor growth when compared to sham surgery performed before implantation. Again, this is measured by IVIS and confirmed by final gross tumor weights. A trend towards significance was also detected between mice who received tumor cell implantation after neurectomy and after sham surgery. So preliminary conclusions from these early data suggest that sciatic neurectomy prior to tumor implantation slows early initial tumor growth, but progression rapidly rises to match that of sham surgery prior to tumor implantation. Also, the similar progression rates of post-implantation sham and neurectomy groups suggests a role for postoperative inflammation in disrupting tumor growth. Now, there are a number of future directions that this research could go for, including an investigation into whether sciatic nerve stimulation enhances tumor growth in a dose-dependent manner, determining whether neurotrophic growth factor supplementation rescues normal growth rate after neurectomy, determination of whether neurotrophic growth factor blockade slows tumor growth rate after sham surgery, as well as interrogation of nerve tumor behavior across other murine sarcoma subtypes and tumors derived from human sarcoma cells. Thank you for listening.
Fantastic. Thank you, Dr. Davitt. Eva Giori from the Medical University of Vienna in Austria will be presenting the next quick shot entitled Schwann Cell Characteristics, Myelination Parameters, and Histomorphometric Analysis of Nerve Biopsies in Polyneuropathy Patients Compared to Controls.
Hello, my name is Eva Placheta-Giori from the Medical University of Vienna. I'd like to thank the PSRC for accepting our study presentation. We have no conflicts. Our study addressed Schwann cell function in polyneuropathy patients compared to healthy controls. Polyneuropathy leads to reduced myelination, and from experimental studies, we know the important role of immature Schwann cell phenotypes and aberrant nerve regeneration in disease progression, although there's very limited data on clinical polyneuropathy patients. In this study, we included 10 patients with polyneuropathy who underwent diagnostic through nerve biopsies, as well as 10 patients in our control group who underwent reconstructive surgeries that included selective denervations of muscle flaps or non-acute autograft nerve reconstructions. Inclusion criteria for the control group were adult patients with no history of neurological disease or recent nerve injuries, no diabetes or cardiovascular disease, and no cytostatic treatments. We harvested nerve biopsies for immunofluorescent staining and histomorphometric analysis of myelinated axons. These are the results of our immunofluorescent staining, and we were able to show a significant decrease of S100 positive Schwann cells in the polyneuropathy group, as well as a decrease of neurofilament H positive axons in the polyneuropathy group. We were able to show reduced myelination as reduced myelin basic protein stainings in the PMP group, and interestingly, we're also able to find P75 positive Schwann cells, which indicate a significant increase of immature Schwann cell phenotypes in the PMP group. These results concurred with the results of the histomorphometric analysis of sural nerve cross-sections, which can be seen here on the left side, the control, the right side, the polyneuropathy. And we were able to show that in the polyneuropathy group, the numbers of myelinated axons as well as axon density and G ratio was significantly reduced. So in conclusion, we're able to demonstrate a reduction of Schwann cell numbers and myelination in this clinical study, as well as an increase of immature Schwann cell phenotypes and a reduced myelinated axon count and axon density. In future studies, we hope to address the role of Schwann cells in the pathophysiology of polyneuropathy, especially the role of chronic denervation and aberrant nerve regeneration in polyneuropathy. Thank you very much for your attention, and all the best from Vienna.
Thank you very much, Dr. Giori. Our next paper is Practice Trends in Plastic Surgery or Plastic Hand Surgery, an evaluation of cases in the ASPS TOPS database, and our presenter is Eric Williams from the University of Florida.
Hello, everyone. Thank you for joining me, and thank you to the PSRC for the invitation. My name is Eric Williams, and I'm a third-year medical student from the University of Florida College of Medicine. The project I'm going to be discussing is practice trends in plastic hand surgery and evaluation of cases in the TOPS database. We have no conflicts of interest to disclose. Surgery of the hand is a certificate available to plastic surgeons, general surgeons, and orthopedic surgeons. Despite making up 20 to 25% of hand surgeons with subspecialty certification in the field, minimal data exists characterizing the clinical practice of hand surgery among plastic surgeons, and there is some evidence that there is a declining presence of plastic surgeons among those performing hand surgery. The purpose of this project was to evaluate trends in hand surgery cases performed by plastic surgeons. This was a retrospective study analyzing the years between 2002 and 2016 using the TOPS database, which is a national clinical registry maintained by the American Society of Plastic Surgeons, and it provides national data for the improvement of patient care outcomes. Our inclusion criteria was based on CPT codes and anatomic classifications, and we studied the period between 2002 and 2016, and cases lacking the evaluated data points were excluded. We analyzed over 182,000 hand procedures performed on 82,811 patients, and we observed that hand-related cases decreased over time from a high of 29% in 2006 to 4% in 2016. 68% of all cases were soft tissue cases, while only 22.7% of cases involved the bone or joint, and these values remain relatively stable over time. While the hospital remained the most common setting, we observed a decline in recent years from over 75% of all cases in 2002 to 50% of cases in 2016. General anesthesia reached the peak of use in 2006 at 69.8% of procedures and has since declined to 33.6% in 2016, possibly related to the increased use in regional and local anesthetic technique. Anesthesia care was provided by the procedural surgeon in 66.3% of cases in 2002 and averaged 20.9% of cases from 2007 onwards. The shift in provider type may be related to the shift away from the surgeon providing sedation and the increasing popularity of CRNAs. The overall complication rate was 2.9%. In conclusion, this study provides a large-scale longitudinal analysis of hand surgery performed by plastic surgeons. Plastic surgeons perform a wide variety of hand-related procedure types, but hand-related procedures may be declining in recent years as a percentage of TOPS cases. Of note, there has been a shift towards anesthesiologists and CRNAs as providers of anesthesia instead of the procedural surgeon, and ambulatory and office-based settings are being increasingly used for hand-based surgery. Thank you for your time.
Great, thank you, Dr. Williams. Our next presenter, Sean Loader from University of Pittsburgh and Pittsburgh, Pennsylvania, will be presenting on fat grafting for dysesthetic digit, a discussion of technique and pilot data.
Hello, my name is Sean Loader from the University of Pittsburgh, and I will be presenting fat grafting for the dysesthetic digit, a discussion of technique and pilot data. We have no disclosures. So injuries to the hand and specifically to the digit are a common trauma, affecting patients of all ages and all walks of life. Between 2002 and 2010, a review of the National Electronic Injury Surveillance System demonstrated over 200,000 emergency room visits for finger amputation at any level, more than 25,000 per year, of which less than 13,000 were amenable to replantation. Despite a wealth of options, these non-replantable injuries remain highly associated with chronic pain, hypersensitivity, dysesthesia, cold intolerance, and contour deficits. And currently, there's no single gold standard for treatment of dysesthetic digit after amputation. Revision surgeries are often necessary with variable results, and we have an acute need for better, effective, and accessible treatments. The solution we will explore here is fat grafting. Autologous fat transfer has several benefits over conventional reconstructive techniques. There is minimal donor site morbidity, and fat transfer does not require extensive debridement or revision of the amputation site. The transfer can treat both aesthetic and functional deficits of the stump at the same time. It does not require complex anatomical knowledge or microsurgical skills, allowing a broader range of practitioners to treat. Furthermore, there is a growing body of evidence that fat transfer brings in healthy, non-traumatized mesenchymal cells. These are widely associated with pro-regenerative changes, including improved angiogenesis, collagen neosynthesis, and in conjunction with ergotomy and fat intercalation, dynamic remodeling of the cicatrix. Additionally, by avoiding local or regional tissue rearrangement, downtime from work and need for further rehabilitation are minimized. Within our practice, we began to harness autologous fat grafting to augment the tissue quality of the scar bed present at the amputation site and to both bulk and remodel the underlying soft tissue to address issues of pain, hypersensitivity, dysesthesia, cold intolerance, and contour deficits. The question for us, though, was how well is this working? We performed a retrospective study of 113 hand trauma patients with digital amputations between 2010 and 2019, of which we selected for those with chronic pain, dysesthesia, or hypersensitivity, and we compared those patients who elected for fat grafting versus a comparison group who elected for or been offered more traditional surgical options. We found that 100% of our fat grafted patients reported improved pain or dysesthesia. 3/4 of those received a single graft, with one patient electing for multiple rounds of grafting. Of the non-grafted group, 66.7% progressed to revision amputation, and there were no revision amputations in the fat grafted cohort. In conclusion, autologous fat grafting, while relatively new to the treatment of the injured digit, is a well-described and reproducible technique with several benefits versus traditional surgical reconstruction. Our pilot data suggests that this is a well-tolerated and effective technique for use in finger dysesthesia after partial finger amputation. Thank you for listening, and I will take any questions.
Thank you, Dr. Loader. Our next quick shot is The Effect of Stem Cells in Locotacrolimus on Neurite Extension by Dr. Sarah Safari from Mayo Clinic.
Hello, my name is Sarah Safari, and today I'll be presenting work that has been performed at Mayo Clinic in collaboration with SickKids. Application of mesenchymal stem cells, abbreviated MSCs, or tacrolimus, abbreviated FK506, to nerve grafts has been a topic of interest to enhance peripheral nerve regeneration. The aim of this study is to evaluate the isolated effects of treatment with MSCs and local delivery of FK506 on nerve regeneration in both autografts and decellularized allografts in vitro. In this study, we will conduct similar treatment groups in autografts and in allografts. Groups consist of negative controls, treatment of MSCs, treatment of FK506, and combined treatment of MSCs as well as FK506. In this 3D compartmented cell culture system, autografts and allografts are harvested and exceeded with MSCs. The dorsal root ganglion provides neuronal cells in this model and is attached to the nerve graft into which it can grow neurites. The system consists of two compartments. The DRG nerve graft construct is placed such that the DRG is in one side and the nerve graft is in the other side. Treatment is applied in the nerve graft side. After incubation, two stainings are used. First, CD90 DAPI staining to confirm stem cell presence and characterization. Second, neurofilament 160 staining to measure neurite extension as a measure of nerve regeneration. This figure shows a macroscopic image of the CD90 DAPI staining. The DRGs are at the circular top and the nerve grafts are attached to it. And in both autografts and allografts, CD90 in green is evident on both MSC groups, which are groups B and D, confirming stem cell presence. In allografts, DAPI in blue is not evident on the nerve graft as opposed to the autograft, which confirms successful decellularization. Quantifying the neurite extension again shows a similar pattern in autografts and allografts. First, both show that treatment of only FK506 or combined treatment of MSCs and FK506 are superior to the untreated nerve graft, the negative control. Second, treatment of only MSCs is found comparable to the negative control. And finally, combined treatment of MSCs and FK506 is superior to only MSCs. Comparing the neurite extension in autografts to allografts shows that autografts are superior to allografts in all respective treatment groups, and comparing the untreated autograft to all allografts shows that only the allograft receiving combined treatment is superior to the untreated autograft. Concluding, the combination of MSCs and FK506 treatment results in significant synergistic increase in neurite extension for both autografts and allografts. Moreover, this study confirms the importance of cellular environment in nerve regeneration and requires the decellularized allograft to be treated with both MSCs and locally administered FK506 to surpass the outcomes of the untreated autograft. Thank you for your attention, and please reach out if you have any questions.
Thank you, Dr. Safari. Now we'll hear from Mana Safari from Mayo Clinic in Rochester, who will be presenting microcomputed analysis of nerve angioarchitecture after combined stem cell delivery and surgical angiogenesis to nerve allograft.
Hi, my name is Mana Safari, and today I'll be presenting work that has been performed at Mayo Clinic. We have no disclosures. Detailed 3D evaluation of microvasculature is evolving to become a powerful tool and could provide mechanistic understanding of angiomodulating strategies. In this study, we aim to evaluate the microvascular architecture of nerve allografts after combined stem cell delivery and surgical angiogenesis in a rat sciatic nerve defect model. 25 Lewis rats were divided in 5 groups of 5 animals each, in which 10 millimeter unilateral sciatic nerve defects were reconstructed using allografts, and allografts wrapped within a pedicled superficial inferior epigastric artery facial flap called the sieve to provide vascularization to the nerve wound bed. In groups 4 and 5, the sieve was combined with undifferentiated and differentiated mesenchymal stem cells. 2 weeks after surgery, the vascular volume and the vascular distributions were evaluated. To provide vascularization to the nerve bed, we used the validated pedicled sieve flap. This flap was raised from the abdomen and tunneled towards the nerve to be wrapped around the nerve graft, reaching both anastomosis. 2 weeks after surgery, vessels were preserved using microfilm injection. Micro-CT was used to make a 3D reconstruction and to calculate the vasculature volume. An aerodilate program was used to analyze the entire vasculature tree and to measure the volume of the vessels at different diameters. These are the obtained figures of the unoperated control, the autograft, and the allograft. You can clearly see that the midsection of the allograft remained avascular. Surgical angiogenesis enhanced the mesh network of microvessels sprouting into the nerve towards the midsection. When this was combined with undifferentiated MSCs, microvessels were seen along the entire length of the nerve graft. This increase was less evident in the differentiated MSC group. Quantified results show that the vascularity was lowest in the allograft, and when sieve was combined with undifferentiated mesenchymal stem cells, this was significantly superior to all experimental groups and comparable to control. Here we see an overview of the vascular distribution with the volume of the vessels on the y-axis and the group diameter on the x-axis. When looking at the allograft group, in yellow, we see that the vessels were smallest in both volume and in diameter. This is the sieve plus the undifferentiated mesenchymal stem cell group, and we see that both the volume and the diameters were significantly increased compared to all groups. In conclusion, surgical angiogenesis contributes to the revascularization of nerve allografts, and when combined with undifferentiated mesenchymal stem cells specifically, this results in the greatest increase of revascularization and in vessel distribution. Thank you, and please reach out for any questions.
Great. I'm going to get to the next one. So thank you, Dr. Safari. Our next quick shot paper is the physiologic signaling of the muscle cuff regenerative peripheral nerve interface during volitional behavior, and it's presented by Shelby Sventek from University of Michigan and Ann Arbor.
My name is Shelby Sventek, and I have no disclosures. Robotic exoskeletons are a promising tool for those with extremity weakness. Most devices rely on surface EMG signals, but they are frequently inaccurate and do not work if little to no functional muscle is present. Our lab has developed the Regenerative Peripheral Nerve Interface, or RPNI, to enable precise control of prosthetics. The RPNI consists of a segment of muscle graft wrapped around a transected peripheral nerve, and it has the ability to amplify a peripheral nerve's microvolt level signals through generation of millivolt compound muscle action potentials, or CMAPs. The RPNI was developed for those with transected peripheral nerves, such as in amputations. However, those with extremity weakness but intact peripheral nerves would similarly benefit from accurate control of assistive devices. In response, the muscle cuff RPNI, or MCRPNI, was developed. Consisting of a similar segment of free muscle graft, it is instead wrapped around an intact peripheral nerve and secured in place. Previous research has indicated it regenerates and becomes reinnervated, thus amplifying these nerve signals. The purpose of this study was to further investigate physiologic signaling capabilities of the MCRPNI and any effect it may have on distally innervated muscle function. This study consisted of 3 surgical groups. One group had an MCRPNI placed on the common perineal nerve, another had sham surgery performed, and the last had the nerve transected. Electrodes were placed in all groups for endpoint testing. 18 male rats were randomly assigned to one of these groups and underwent surgery. At 6 months, all constructs were exposed, and rats then underwent electrode implantation for endpoint analysis, with an example of an implanted electrode shown at the top right. At endpoint, all MCRPNIs were found to be viable with visible contraction. The image on the right shows immunostaining of a longitudinal section, and a close-up of this image reveals intact neuromuscular junctions with appropriate staining. All rats underwent gait analysis with implanted electrodes to track signaling during ambulation with representative output from an MCRPNI electrode shown at the bottom. MCRPNI signals measured 0.5 millivolts on average and appear to correlate with hind limb dorsiflexion. In situ electrophysiologic testing produced average nerve signal amplitudes of 51 microvolts, while average MCRPNI Cmaps were 2.8 millivolts. This produced an amplification factor of 55 times, easily enabling differentiation of these MCRPNI signals from background noise, unlike physiologic nerve signals. Muscle force testing was also performed on distally innervated EDL muscle to determine the impact on distal muscle function. Maximal tetanic muscle contraction produced similar forces in the control group on the left and the MCRPNI group in the middle. The nerve transection group at the bottom right did not demonstrate any EDL force. In summary, results from this study have demonstrated that MCRPNI can amplify a contained nerve signal up to 55 times, enabling differentiation of the signal from noisy background noise. Additionally, the signal amplification occurs in line with hind pod dorsiflexion during ambulation. Furthermore, this amplification occurs without negative impact to distally innervated muscle. Thus, the MCRPNI has the potential to act as a biologic nerve interface for intact peripheral nerves and may allow for intuitive and accurate exoskeleton control for those individuals with extremity weakness but intact peripheral nerves. Thank you to PSRC for this opportunity, as well as the PSF and NIH.
Great job, Dr. Swiatek. Next, we have Dr. Kiana Tejdaran from the Hospital for Sick Children in Toronto, who will be presenting the role of the TrkA and P75 receptors in corneal wound healing.
Hello, everyone. My name is Kiana Tejdaran, and master's student at Dr. Borsh's lab at the Hospital for Sick Children. Today, I want to talk about the role of NGF receptors TrkA and P75 in corneal wound healing. The condition that we are working on is called neurotrophic keratopathy, or NK. Well, what is this disease and how it affects our patients? NK is a corneal neurodegenerative disease, and loss of corneal innervation leads to corneal epithelial breakdown and vision loss. The three most common etiologies are HSV infections, diabetes, and intracranial tumors. Even though that a surgical treatment available, we always try to move toward a non-invasive treatment. And that was the rationale behind introducing NGF eye drops as the first non-invasive treatment for NK, but it really didn't show promising results in the patients with later stages of the disease. So here we are today, and our objective is to understand the molecular mechanism of NK to develop a new non-invasive treatment. Previous studies of the role of TrkA and P75 in other systems showed that these two receptors have opposing roles, and in the neurodegenerative states, TrkA activity is suboptimal or completely absent, and as a result, we can see activation of P75. So to find out if these two receptors mediate the same biological actions as other systems in the cornea, we used a transgenic animal model that allows for specific inhibition of TrkA receptor. Animals were divided to 3 groups, including a control group, TrkA inhibition, and a group that both TrkA and P75 was inhibited. And then we did corneal deepitalization and fluorescein healing assay. In the first row, we can see corneal healing from the control group, which normally happens after 48 hours. But we found out that by inhibiting the biological action of TrkA, we have a significant delay in the recovery. And if we inhibit the P75 receptor in the context of TrkA inhibition, we can accelerate corneal healing. This graph shows us the epithelial recovery percentage over 96 hours. And if we compare the green bars to the gray bars, we can see that by inhibiting the P75 receptor, while TrkA is also inhibited, we have a faster corneal recovery. So these findings support the idea that if we use a TrkA selective agonist or P75 inhibitors, we can treat NK. Thank you for your attention.
Thank you, Dr. Tejdaran. The next quick shot is determining the critical time of chronic Schwann cell denervation on functional recovery and RNA expression. And the presenter is Allison Wong from Johns Hopkins University.
Thank you. I have no disclosures. We know that functional recovery is poor after nerve injury. Once a nerve is denervated, the Schwann cells change to a repair phenotype that becomes senescent if axons cannot reach their target. And this has been recently proposed as the true basis for diminished functional recovery after delayed peripheral nerve repair. So we wanted to investigate the specific temporal effect of Schwann cell denervation on functional recovery, as well as changes in RNA expression that may elucidate changes in recovery potential. To do this, we developed a novel rat forelimb model that isolated Schwann cell denervation. In the functional recovery arm of the study, the ulnar nerve was transected proximally, and after a period of 8, 12, 16, or 24 weeks, we performed an in situ nerve transfer of the median to ulnar to median nerve. Functional recovery was then measured weekly with stimulated grip strength testing for 12 weeks. In the RNA expression arm of our study, both the median and ulnar nerves were denervated unilaterally. The same time points were used with the addition of a 1-week denervation group. After the respective denervation periods, the median and ulnar nerves were harvested bilaterally so that we would also have a naive control. We then processed and analyzed the nerves to create our RNA-seq dataset. This is a figure showing our in situ nerve transfer. Our functional recovery data showed that after 16 weeks of denervation, there was significantly diminished functional recovery. Our RNA-seq results identified 1,624 genes that were differentially expressed. Of these, 327 were upregulated and 1,297 were downregulated, and this is a representative heat map of that. We then performed gene ontology by doing a weighted correlation network analysis. This is a statistical method that identifies clusters or modules of highly correlated genes. We identified 9 distinct modules and then matched these with the gene ontology database to identify relevant gene families and pathways. Though we identified 9 gene modules, these 3 are particularly interesting as they demonstrated expression changes between the 12 and 16-week periods where we saw the drop in functional recovery. Gene ontology showed that these modules were associated with cell cycle, vesicle-mediated transport, and oxidative phosphorylation. In conclusion, Schwann cell denervation of more than 12 weeks results in significantly worse functional recovery, and our RNA sequencing demonstrated that not only were there many genes differentially expressed, but these appeared to vary with duration of denervation. Further investigation into the specific genes and their changes over time will allow us to know why recovery potential is decreased and targets for interventions to improve recovery. I'd like to thank everyone who helped with this study.
Thank you, Dr. Wong. The final paper in this quick session is Clinical Practice Patterns in Evidence-Based Medicine in Dupuytren's Contracture, a 12-year review of continuous certification tracer data from the American Board of Plastics. This is presented by Selçuk Yüksel of Feinberg School of Medicine in Chicago.
Hello, my name is Selçuk Yüksel, and today I'll be talking about clinical practice patterns and evidence-based medicine in Dupuytren's contracture. I have nothing to disclose. So the American Board of Plastic Surgery tracks 20 plastic surgery operations called tracer procedures as part of their continuous certification process. Every 3 years, surgeons must report data on 10 consecutive patients, making these data an ideal way for surgeons to stay up to date on trends in clinical practice. There were 230 cases of Dupuytren's contracture entered into the tracer in the past 12 years. There are various surgical and non-surgical approaches to Dupuytren's, and literature conflicts on which has the best outcomes. To give some background on the literature, despite longer recovery times and high complication rates, limited fasciectomy has the best improvement outcomes in the short term. High-level evidence shows that percutaneous fasciotomy has similar results to limited fasciectomy with better direct hand function in early disease. However, the difference is that limited fasciectomy has a 5-year recurrence rate of only 5%, according to the literature, while percutaneous fasciotomy has a recurrence rate of 22%. Meanwhile, invasive procedures such as radical fasciectomy have high complication rates, more need for skin grafting, and prolonged post-operative rehabilitation times, and literature shows that they are no longer commonly used. Compared to limited fasciectomy and other invasive techniques, Clostridial collagenase injection requires less time, has faster recovery rates, and fewer serious adverse events. However, it does have a higher 5-year recurrence rate than any surgical approach to Dupuytren's of 47%. In our analysis of the tracer, limited fasciectomy was the most commonly performed procedure, comprising 62% of cases, which mirrors nationwide statistics. This was followed by radical fasciectomy, 24% of cases, and percutaneous needle fasciotomy, which made up 7% of cases. When we split the tracer time period into half and compared trends between these two periods, we saw a significant increase in the use of percutaneous fasciotomy, possibly as a result of literature advocating for its efficacy. There was also a significant decrease in radical fasciectomy tracer cases from 34% to 16%, which also mirrors nationwide statistics showing that aggressive management techniques such as this are no longer commonly used. We also saw a significant increase in the use of collagenase injections in the tracer, which makes sense given that this technique was made available in 2010 and has become increasingly popular since. Finally, a noteworthy trend that we saw in the tracer was a decrease in the use of postoperative splinting and formal hand therapy. Although the majority of surgeons still perform these over the time period collected by the tracer, there is little evidence in the literature to support routine postoperative thermoplastic extension splinting after fasciectomy. Further research is required to define patients who might benefit from routine splinting. Thank you.
Thank you, Dr. Yüksel, and to all of our quick shot presenters. Phenomenal job this evening. We now should have everyone back from the breakout room, and I would like to introduce our next invited speaker, Dr. Paige Fox from Stanford University in Palo Alto. She'll be speaking on global hand surgery outreach, access, and quality of care.
Hi, my name is Paige Fox. I'm from Stanford University, and tonight I'll be talking about global hand surgery outreach, access, and quality of care. I have no disclosures. In 2015, The Lancet determined that 5 billion people don't have access to necessary, safe, and affordable surgical and anesthetic care, and an additional 143 million surgical procedures are needed in low and middle income countries annually to prevent disability and save lives. From a monetary perspective, about 7.9 trillion of GDP will be lost worldwide over the next 15 years from decreased economic productivity due to injury, with losses greater than 50% in low and middle income countries than high income countries. Of all causes of mortality in low and middle income countries was reduced to the level seen in high income countries, greater than 2 million lives, 50 million disability adjusted life years, and 786 billion could be saved annually. Addressing worldwide disparities in injury burden and access to high quality care is essential for achieving health equity. The field of global health has grown immensely in response to this, with remarkable progress being made. While once considered a field focused on infectious diseases, today it has grown to encompass many medical and surgical specialties. Global health today is defined as the study, research, and practice of improving and achieving worldwide equity in health. While the increased interest in outreach in low and middle income countries is lauded, these endeavors can be improved with parallel efforts to ensure delivery of safe and high quality care. While greater than 6,000 medical trips costing $250 million annually are sponsored by the US, it's critical that these trips are conducted appropriately. To put things in perspective, imagine you run your normal week, operating, going to clinic, and then the next week you fly to Africa with an HVO. You don't speak the language. You've never been to Africa before. You head into a case. It's a giant cell tumor of the distal radius. You don't know if the consent's been done. You don't know what discussion was done with the patient, and you don't know who's going to follow this patient post-operatively. You don't know if they can handle the complications. You don't know what or who you displaced by performing the surgery on that day. This example, or at least parts of it, are not uncommon when operating in low and middle income countries. Assuring quality is just as important as ensuring access. Currently, access does not equal quality, but the vision is that someday access does equal quality. These are just a few things we do in developed countries to ensure safe and high quality care. Not adhering to these mistakes could cause risk of harm to patients. Not surprisingly, many of these things are difficult even in settings with abundant resources. And many are notably absent or infrequently done on trips to low and middle income countries for a variety of reasons listed here. I'll go through a few things we've done to study these barriers and help get around them to improve care in low and middle income countries. In thinking about quality in the States, we frequently follow this framework of structures, processes, and outcomes to help us characterize and analyze different aspects of quality at our hospitals. I've included some examples here to help characterize the various aspects of care. These processes and ways of thinking happen frequently in healthcare systems in developed countries. However, we don't know what's done in low and middle income countries when people go on trips. To determine the baseline quality care in low and middle income countries, Shapiro et al. Conducted a systematic review to ID candidate quality measures relevant to orthopedic surgery. The group, while looking at hand surgery, chose relevant orthopedic surgery as they felt this more closely aligned than plastic surgery. The group then classified these measures based on the standard Donabedian framework, as well as the frameworks of systems management and sustainability laid forth by Beto et al. As a conceptual model for the evaluation of surgical outreach trips. Their systematic review included 26 articles, from which 79 candidate quality measures were extracted and classified. To be brief, you can see that only 14 measures were related to outcomes. We can see that that means that quality measures addressing orthopedic surgery outreach trips are lacking in quantity and breadth. This limits the ability to assess and improve the safety and quality of the care provided. The quality measures identified disproportionately focus on systems management and structures, with very few related to sustainability and outcomes. Patients receiving care on outreach trips would benefit from the implementation of measures identified in this review and from the development of quality measures that capture all domains and emphasize outcomes. Therefore, our first goal was to establish these quality measures. To accomplish this, we joined up with a consortium of 10 hand surgery experts in global health who had the same vision to ensure hand surgery outreach in low and middle income countries is the same quality as that in developed countries. And the group had the mission of measuring and improving quality of care and building capacity for hand surgery in low and middle income countries. We first developed a tiering system based upon the resources that are available at any outreach site and deemed these essential, intermediate, or advanced. This allowed us to classify the application of measures as care delivery in low and middle income countries is often constrained by local resources. These tiers were placed within two frameworks discussed previously. Additionally, we followed the recommendations set forth by the World Health Organization for practice guideline development. We used the results of the systematic review to inform the development of quality measures. The consortium completed a Delphi process. The steps are shown here to evaluate the importance, feasibility, usability, and scientific acceptability of all the measures. Validity was defined according to established methods. This method is frequently applied to develop appropriateness criteria that have face, construct, and predictive validity. 22 of the 83 quality measures were validated. Here are a few shown on this slide. We believe that these measures, if followed, can help ensure safety and the delivery of high quality care on hand surgical outreach trips to low and middle income countries. The next challenge is how to measure and collect this data. We've defined what to collect, but now we need to know how to collect it. In low and middle income countries, data collection, especially via an EHR, is uncommon and is a barrier to quality measurement and improvement. Medical records are typically inadequately supported and poorly managed. They're often illegible and require significant administrative time and attention. They often provide little utility after the patient is discharged, and sometimes even while they're inpatient. We've recently set out to develop an EHR for use on these outreach trips to low and middle income countries. In learning from electronic health record implementation in developed countries and from electronic registries that already exist in low and middle income countries, we wanted to address this problem in a thoughtful, methodologic manner. Successful implementation is predicted on understanding the context of where the system will be implemented, the content of what will be implemented, and the process of how the system will interact with patients. We first address the content of the EHR, or what exactly will end up in the health record. We conducted a review of the literature and currently use data repositories. We use the similar Delphi process to validate the items, which would then be placed into the EHR. From our consortium, experts from the groups listed on the left helped provide data to include within our EHR. As we all know, the processes for care and data collection vary. There are various touch points and various roles and responsibilities of who collects the data and who inputs the data. Without a defined and agreed upon process, much of this data collection doesn't occur. This current state process map was developed through semi-structured interviews with global health experts, which we subsequently developed into a future or ideal state process map through the Delphi process discussed earlier. In the background, much of this work, and in order to make this work, we must understand the context at each site. Focusing on our partner hospital in Ho Chi Minh, Vietnam, we conducted an interview study of barriers and facilitators of data and outcome collection. We interviewed 17 surgeons, administrators, and patients to better understand data collection. In accordance with the theoretic domain framework, a conceptual model I developed to identify behavioral influences and that serves as a lens through which to view how various influences affect behavior. These representative quotes give us insight on how to tackle these barriers to quality measurements and outcome measurement implementation in each country. Speaking of implementation, that was our next goal. My colleagues at Hospital for Special Surgery and Stanford partnered to assess the current implementation of the quality measures at 9 different hand surgery sites around the world. The primary aim was to determine the 22 validated quality measures across the 9 hand surgery sites and see how often they were implemented. This was done through a retrospective study via survey. Multiple independent trip leaders and Touching Hands project leaders were surveyed at the countries listed below. 50% of the 22 quality measures were currently being implemented at all 8 sites. Quality measures were being documented roughly half the time by the visiting team and half the time by the local hospital. These are a few of the quality measures that were implemented at 100% of sites. However, many of the quality measures were implemented at less than 100% of the sites. Some of these quality measures are harder to implement, such as presence of an oxygen supply and documentation of a complete backup plan. However, some are imperative and much easier to implement, such as the surgical timeout and patient marking. As you can see, all sites had greater than 70% compliance with the quality measure implementation. We hope through education and resource assessment, we can reach 100% compliance at all sites, ensuring quality of care at these hand surgery outreach sites. As you could see from the prior study, some of our validated quality measures are easy to implement, but some are much more difficult. And one of those is patient-reported outcomes. Even in the US, it is hard to collect long-term patient-reported outcomes. The challenges are even greater in a low and middle income country. It's hard to reach patients to see how they're doing after surgery. And for many of the reasons we discussed above, financial concerns, travel concerns, patients can't come back for regular postoperative visits. In low and middle income countries, patients often live hundreds of miles from the hospital or clinic. They're resource poor and have difficulty following up. Studies of tibia fracture rates and follow-up from Uganda and Madagascar noted only a 44% follow-up rate at 3 months. To combat the difficulty in travel, we set out to use cell phones to facilitate patient-reported outcome collection. Fortunately, as demonstrated in the graph on the left, cell phone and data network penetrance is high throughout the world. We partnered with Memora Health to pilot a study to collect outcome data post-operatively on patients whom we operated on in Vietnam. This is a HIPAA-compliant, SMS-based platform through which we can text message patients for data collection and then send them outcome surveys at no cost to the patient. We used the Quick Dash for this. We translated it and contextualized it to the Vietnamese population. And our initial data is promising. Typically, follow-up rates after surgical outreach trips range vastly and often are very low. And using this system, we acquired 3-month follow-up of 100%. This is a figure depicting how the patient's Quick Dash scores are decreasing over time, indicating for the most part that they are improving. Mean Quick Dash change was 21.63% in the negative direction. However, we were able to interact with our patients remotely and check on the 2 patients that were not showing the proper trend in Quick Dash. One of these patients is awaiting a secondary planned procedure, and the second one is improving, just not on the time course that we would have hoped. So what's next? These are a couple of our next and bigger picture steps. We plan for further implementation and pilot testing, longer-term outcome assessment. 3 months isn't enough. We want to expand the scope and scale. And then we want to disseminate these quality measures to help implement them in all outreach trips, not just hand surgery outreach trips. And then we'd like to capacity build at these sites. No work can be done alone, and this is the consortium that I mentioned earlier, the Global Quality in Upper Extremity Surgery and Training, or QUEST Investigator Group. I'm honored to be part of this group with such a distinguished faculty. Thanks to the people on this slide who have been integral in teaching me both here and abroad.
Thank you, Dr. Fox. That was such a great talk on global outreach and global surgery. I want to open this time now for any questions for Dr. Fox. If anyone wants to speak up or use the chat function, I will start with one question. I saw a picture of Dr. Chung with you, and he has taught us a lot about global outreach and global surgery. And I think that one of the really key points about making access equal quality care is that you need to get optimal buy-in from the physicians and caregivers that are at the actual location that you're going to go to. And so I was wondering, do you have any advice and any kind of points on how to optimize that type of buy-in? Because obviously once you leave as a surgeon, someone, as you mentioned, has to follow that patient and take care of, say, complications. How do you get the local doctors to do that? And also, I have to imagine that there are a lot of cultural differences in all of these countries. You must have examples of how those cultural differences have created challenges in having these surgeons take care of these patients.
Thank you for those questions. Yeah, so for the first question, it is imperative that you pre-trip plan, and that even before you place your boots on the ground in any country, that you have some relationship or some buy-in from that surgeon, that country. Sometimes you even need it from the Ministry of Health in some countries. Or, as you said, you won't be able to follow up because they don't have the same buy-in. The other part of it that I think is imperative is that your first trip is a small trip. It's a feeling out trip. You need to find out what are the resources, what is the buy-in, and what are the limitations, both structural limitations as well as financial limitations of the site that you're visiting. And so there's a lot of planning that comes in to this ahead of time, and a very small trip the first time to make sure that you have a really good grasp of the barriers. In regards to your second question, which is, how can we address the barriers at sort of each site? You're correct. It's different at each site, and the role of the Ministry of Health and the role of the town and the city are all imperative. And so again, when we go on these trips, part of it is finding out what are the barriers to care currently and how do we knock down some of those barriers. As you saw, there were originally 80 quality measures and only 22 of them were usable, feasible, practical, because many of them are things that we would hope for 20 years from now, but currently we could only say about a quarter of them were practical.
I see. Thank you very much. Are there any other questions for Dr. Fox?
I have one. Paige, thank you so much. Like, I just get so amazed with, you know, all these other aspects that I think that we can do as plastic surgeons, and this outreach is, you know, world and life changing. So I'm going to bring it back to our COVID world. So have you all talked about with, you know, now as we're coming hopefully on the other side of the pandemic, when these trips and outreach and science is going to continue or get back started? Any idea?
Well, I have a trip planned in September and a trip planned in February, just in case the September one doesn't happen. So I am optimistic, but practical. But another part of this outreach is the capacity building part, the part that someday we turn over the reins and it isn't us doing the operations. It's just us supporting them from afar. And you've taught the surgeon there to do it so that when the next pandemic comes around, it's not 2 years where a low and middle income country has no hand surgeon providing care.
That's right.
Because delayed trauma is the most common thing that we see on these trips, or delayed burn care for the hands. And I mean, nerve transfers are many years away, but even tendon transfers, you know, are not something that are getting done. And so educating those surgeons in those countries is what ultimately is, you know, the big 10,000 foot view for this project.
Yeah, that's great. Well, congratulations and thank you. Look forward to supporting it.
Thanks so much, Paige. That is a, you know, huge volume of work that you just presented to us so nicely. So thanks for all of your efforts on that. And I wondered if you could just make a few comments about the importance of the team and how integral is it to, you know, have the same team working together, or are a lot of the components interchangeable as long as everyone's, you know, supporting the same culture and practices?
That is something that I've been on both types of trips. The trip where you have a different set of people that come each time, and the trip where it's the same people each time, both the same people you're educating and you yourselves as the educators are the same people. And I think that going back to the question about buy-in, your buy-in and their buy-in is much greater if they see the same face at least once a year, at least every 6 months on a conference call. So I think that some continuity is important. Is it okay to have, you know, one different person on the trip each time? Yes, but I think that there needs to be a constant. And I also think it's about having, which hasn't been possible in COVID, but having repeated contact points on these trips so that you're not just going once a year, but that someone is going, it's planned that someone will be there every 6 months, and that every 3 months you'll have a Zoom. Now we're all very facile at Zoom. You'll have a Zoom meeting to talk about patient follow-up or difficult cases, and just that really builds that relationship that is key to the success here.
Fantastic. Thank you.
Thank you, Paige.
Thank you.
So tonight would not be possible without the generous support of Synovis MCA. And I'd like to introduce to you all Max Siniglio, who is the Global Dermaclose and Nerve Clinical Manager for Synovis MCA. And he will be speaking on a different approach for fasciotomy wound closures.
Good evening, everybody. I will briefly talk tonight about a different approach to fasciotomy wound closure. My name is Dr. Massimiliano Ciniglio, and I am the Global Clinical Manager for Synovis MCA. My disclosure is that I'm a full-time employee of Synovis MCA, who is the maker of Dermaclose. talking a little bit about acute compartment syndrome, we know that it places the skin and the underlying tissues under significant pressure. Once this pressure is surgically released, the tissue may need some time to recover before tension can be applied to attempt closure of the wound. The resulting wounds may be closed either by secondary intention, delayed primary closure, split thickness skin graft, or tissue transfer flap. Although the skin grafting remains a mainstay in many practices, the associated secondary contraction can cause painful theater scars, decreased range of motion of the underlying muscle, and sensitivity to pressure or touch. Delayed primary closure is really associated with better cosmetic appearance, less scarring, and improved motion of underlying muscles. Early closure may also save time and resources, and this can be achieved through continuous external tissue expansion. The continuous external tissue expansion can be used before definitive closure to bring the wound edges closer. It may then negate the need for a skin graft or just reduce the size of the graft that it's needed. So we know that tissue expansion for reconstruction of soft tissue defects has been used for decades. In fact, the most common technique that we all know is the Jacob's ladder technique using vessel loops, as you can see there on the pictures, which are the well-known elastic bands. I'm not going to really talk much about the two main factors that play a main role on the expansion of the external tissue and the approximation of the edges that might facilitate the closure of the wound. But those two factors are the biological creep and the mechanical creep. So basically, you know, by having this mechanical tension force will, you know, generate a cycle or a different series of biological creep and different cycles of several components that of course will, you know, initiate a cascade of events and will facilitate this expansion of the dermis and the epidermis and the connective tissue, creating this abundance of tissue that will help approximating the edges of that wound and hopefully being able to close it in a delayed primary fashion. Now, the limitation over time of this technique and basically what has, you know, in the past not really permitted this continued external tissue expansion to take off is that the device, the limitation of the technique and other devices lies in the degree to which they maintain tension on the wound edges, as the applied forces tend to decrease over time. And this is where this device known as the Dermaclose makes a whole difference. The Dermaclose per se was launched back in 2007 as a continuous external tissue expander with the indication for use in assisting with the closure of moderate to large surgical or traumatic acute full thickness wounds of the skin by approximating and reducing the size of the wound. Now, the Dermaclose, or the device per se, the way it actually works, it contains an internal tension controller that maintains a constant tension force of about 1.2 kilos on the edges of the wound. This Dermaclose will self-adjust to the loss of tension on the wound, accelerating the approximation process and consequent wound closure. So the degree of the expansion and approximation achieved by its placement is optimized via this constant stretch stimulus. So this basically tension force never really stops. It keeps going over and over, and it's pretty much self-automated. So it will keep going on until it gets to the maximum stretching or maximum tissue expansion, with the main idea or goal to approximate those edges for a delayed primary closure. Now, the device per se, it's pretty simple. It consists of 6 skin anchors, that they penetrate the skin in about 4.5 millimeters. It has, as I mentioned before, a tension controller that delivers this constant tension force of 1.2 kilos. And it also comes with a skin stapler because we need to staple the anchor to the skin to keep it in place for the further lacing technique of the controller so it can start expanding the tissue. Here you can see what we know as the basic 6 anchor technique. And it is very similar to, the lacing technique is very similar to a shoelacing technique, but it's very important to keep that precise technique because it will actually distribute the force equally among the 6 anchors on the skin. So it's something that we have to learn to do to make sure that the device will work properly. And this is another drawing on how this 6 anchor technique lacing is teach about. And it's, as I said, it's very simple, but it's important to follow precisely. Here on a little fact sheet of the Dermaclose, what we actually try to explain is the position of the anchors as far as how far from the edge of the wound and how much separated between each other. So basically, usually for every 10 centimeters of length of the wound, we will use 1 set of Dermaclose. So if the wound is bigger than that, we start adding Dermacloses to the wound. And then the other part that it's, or the other measurement that it's important to keep in mind is the width of the wound. That's because we have 2 types of Dermaclose. We have a regular Dermaclose and an extra large. The extra large is really intended for wider wounds, and it's really the same mechanism. You just have more nylon inside the controller, so it makes it very easy to lace those wounds that are wider in dimension. Here is just a few pictures on how to apply the anchors and how to secure the anchors to the skin with the stapler, and then of course the controller. The Dermaclose is really not a brand new device out there in the market. It's been out in the US market for about over 10 years now. And then recently, less than a year in the European market. It actually was just launched in the European market a few months ago. But in the US, the experience is pretty large in volume. At this point in age, we've done over 25,000 Dermaclose cases. And there is a little bit of literature, actually quite a little bit, over 50 case reports. There is over 22, 23 actually papers that have been published on different applications of the Dermaclose. And as I said before, of course, we have a long tenure of usage over the years, no really very low complaint rate at this point. So it's a very safe device. What I wanted to do next was to show you, because of course we're talking about fasciotomies, and I will say the fasciotomies are the bread and butter of the use or the indications of Dermaclose, even though it can be used pretty much for any type of wound that it's difficult to close immediately in a primary fashion. So basically, it could be anything from abdomen wounds, scalp wounds, cancer-related wounds. It could be trauma, of course, related wounds, foot and ankle, diabetes wounds. So the indications are really endless. But what we see year after year, fasciotomies are really a big part of the usage of Dermaclose. And so here, of course, you see a characteristic wound shape of a fasciotomy after a compartment syndrome. In this particular case, the Dermaclose was used in conjunction with a VAC system, a negative pressure system, which actually can be used with no problem. And they interact between each other, but they don't really, the VAC will not interfere with the expansion of the Dermaclose, and the Dermaclose will not interfere with the vacuum system of the VAC. Here is another example of a fasciotomy on a gunshot wound patient. And usually the average is exactly what you see there. In fact, there is a paper that was published a few years ago from Walter Reed, where the average time on fasciotomy wounds using Dermaclose was about 4.5 days. Of course, we've seen quicker expansions of about 2 days, literally 48 hours, but we also seen cases where it takes a little bit more than 5 days for the tissue to expand and approximate to the point that you can either close the wound just with sutures or staples, or sometimes you might need to add a smaller size graft to fill the gap. Another fully closed fasciotomy using Dermaclose, as you can see again, very quickly, about 5 days. This is another example on the forearm, which the wrist area could be a challenge sometimes because there's really not a lot of really a lot of real estate skin, so not really much to expand from if the gap is pretty large. But here, surprisingly, with the Dermaclose, in a matter of about between 5 and 10 days, it was approximated fully and been able to close with sutures. This is another classical medial and lateral fasciotomy on the lower limb, and we can see how Dermaclose was applied on the lower lateral medial fasciotomy, and the results were also very good again with a full approximation and being able to close that wound. Here is another fasciotomy also on the lower limb. So the closer you get to the ankle area, the more challenging it is because, again, you don't have a lot of skin to stretch from. But we've actually had a lot of success with ankle wounds and foot wounds where there's little skin. But still, the skin in that area is very given, and it will stretch very well to the point that you can pretty much expand and approximate those edges. And this is a classical presentation of a very large wound utilizing 5 Dermaclose. And you see the orange one, as I mentioned before, those are the extra large. So basically, if you have a wound like this that it's wider in the middle, usually the measurement we take kind of as an indication to go to the extra large is 8 or more centimeters in width. So if you have a wound that it's wider than 8 centimeters, we suggest you use the extra large instead of using the regular, just because you have almost double the amount of nylon, and it will make your life much more easier to lace that Dermaclose around such a wide wound. And that's really all I had. Again, this is, as I mentioned before, is a very well-known device for fasciotomies, and it really kind of gives you an extra tool in your bag if the graft or any other solution for a patient that has a fasciotomy wound, it's not really a good candidate for those ways of closure. You can always think of a continuous external tissue expander like the Dermaclose. And as I said before, the experience has been very positive. In fact, more than quite a few papers have been published specifically only on fasciotomy. And of course, the indications and the applications of the Dermaclose goes beyond just fasciotomies. It can be applied pretty much to any type of wound that it's difficult to close immediately. Hopefully you guys have found this little lecture interesting, and you will consider in the future a continued external tissue expander for your difficult wounds to close. Thank you very much, and enjoy the rest of the meeting.
Excellent. So thank you, Dr. Cinaglio. We are always grateful for the support of our generous donors. So very exciting. What a great evening. And I want to thank my co-moderators, Dr. Snyder-Warwick and Dr. Kong, because we've had a lot of fun trying to put this day together. And I'm excited to introduce our next set of panel to end the evening. I don't need to have much of an introduction to any of our speakers of this panel, but we are going to have this group of previous chairs give us their opinion of the greatness and defeat in the sport of plastic surgery and lessons learned. And the idea we set forth was, what is a case or a scenario that either you learned from or that you wish you knew now, that you didn't, or you know now, but you didn't know then. And so our esteemed colleagues of this panel, as you can see here, now we're in our gallery view, Paul, as Dr. Soderna from Michigan, you're going to start us off, and then we're going to go from there and have a lively discussion after the panel gives their presentation. So thank you so much for being here.
Can you hear me now? Am I good?
Yes.
All right, excellent. Well, thank you very much. So I too want to congratulate Dr. Moore, Dr. Allison Snyder Warwick, and Dr. Kung on all their efforts in putting it together. And I'm actually pleasantly surprised to see as many people here that are here. And I think that's because of the quality of the program and because we all love nerve more than anything. So anyway, I'm going to talk a little bit about greatness and defeat in the sport of plastic surgery lessons learned. And so really, in general, I'm not going to talk about greatness because I don't think that's actually too important here. So I don't really want to talk about that at all. But I do want to consider defeat and how I actually think about defeat and what that actually means to me when we consider the sport of plastic surgery and actually the sport of life. So if we look at the writing of John Steinbeck, we see him saying, somewhere in the world, there's a defeat for everyone. Some are destroyed by defeat, and some made small and even mean by victory. Greatness lives in one who triumphs equally over defeat and victory. And so for me, when I think of greatness and defeat, I don't think of defeat at all. I actually think that there is no such thing as defeat. There are only opportunities to learn and get better. And that's why I'm going to start talking a little bit about a journey I've been on for the past 15 years to try to develop a way to interface with peripheral nerves to improve prosthetic control. And this journey started in 2006, and I'm going to tell a story about the bioartificial neuromuscular implant that none of you have ever heard about before, but it's a thing we worked years on. And I'm going to talk about this because of all the lessons that I learned along the way in an attempt to create this peripheral nerve interface device for prosthetic control. So what this was is this was a design we created on a whiteboard like we do most of the time as we take all of the ideas and we throw them up there and we try to figure out what's going to work. We have constructs, we have nerves, we have probes, we have myocytes, we have everything here. And ultimately we came up with the banh-mi. And so what it was is it was an acellular container, and in that acellular container, we would add electroconductive polymer, PDOT, which would increase the conductivity of this container to get signals out of the nerve. We would take cultured myocytes and add them in as a source for the nerves to reinnervate. And ultimately then when efferent motor action potential would come down, it would actually activate these muscle cells. We'd use the polymer and we'd take the signals out. So our first goal was to make these acellular constructs, and we were actually successful in developing a technique to acellularize these tissues and develop these beautiful acellular nerve constructs. And when we finished this part of the process, we were like, sweet, fell in the bathtub, didn't break a hip, great success. So we're winning so far. So this is going well. So then our next step was, okay, was it immunogenic or not? Because if we're going to be developing these and we're going to be putting them in humans, they can't be immunogenic. And so we did a whole bunch of neuroimmunology studies looking at the chemical acellularization process and eliminating allograft antigenicity. And we showed significant reduction in Th1 and Th2 responses. So right there, I thought, okay, that's great success too. But what I just said in that last sentence is essentially the extent of my knowledge of neuroimmunology. And when I think of neuroimmunology, I think of this chart right here, and there's a lot of stuff going on. And frankly, I'm not that interested in any of this, but now I found myself doing neuroimmunology. So I find it incredibly challenging. It's not my area of focus and not my area of interest. So one of the big lessons I learned here is people say that winners never quit. And I completely disagree with that. I think winners quit all the time. They just quit the right stuff at the right time. And for me, transplant immunology is something I needed to quit because although it was getting me going in the direction I wanted to develop this interface, it's not something I knew anything about, nor was it something I wanted to learn anything about. So along the way, we also then started seeing if we could actually get nerves to reinnervate on myocytes that were in culture, along with our electroconductive polymer, and would axons regenerate in these constructs? And we were able to successfully demonstrate that as well. And so along this entire process, we made a lot of progress. We spent millions of dollars. We wrote a number of papers, but the reality is although I love this design and I thought it was really elegant and really cool, and we made so many things work that were so much fun, the reality of the whole thing is PDOT was something we were using in it, which wasn't approved for implantation in humans, so we couldn't really use it. Our cell culture approaches were not approved for implantation in humans, huge regulatory hurdles. Neuroimmunology was not an area of my interest or expertise. And the acellularization techniques weren't really scalable at a larger level. And so in reality, as much as I love this idea, we spent a lot of time going down a lot of paths to create something we could never put into humans. So the second thing I learned is failure. Failure is an important part of innovation, and probably the most important part of innovation overall is failing, accepting that failing, and moving on, moving in a different direction to create what you want. So that's what led us to the regenerative peripheral nerve interface that some of you have heard about before. This technique is simple, it's easy. There's only one element to the whole thing, and it's the exact opposite of the banh mi. We take a nerve, we take a small piece of muscle, we wrap it around the end of the nerve, and that is it. The nerve reinnervates the muscle amplifies the efferent motor action potentials, we record the signals. And so what happens is we take a nerve like this, we divide it into fascicles, we attach a little piece of muscle on the end, and we have as many control signals as we want. And when we do this in a human, we can see him moving his DECA hand here, and he's moving it very naturalistically just by using his brain and moving his fingers like he did with a normal hand. It is absolutely amazing. And when we watch him move his thumb here, he's moving his thumb using 4 different independent control signals to control the position of that thumb. And knowing that thumb is half of the hand function, we know how important that is. And this is another one of our patients who is actually demonstrating the ability to control each of her 4 fingers. And she's doing this merely with her peripheral nerve signals and her RPNIs, nothing fancy, something that anyone can do anywhere. So what lessons did I learn? I learned that a lot of times something that seems so cool, despite the fact that it's really cool and it's fun to work on, isn't that important. And I learned that many times we all have this idea in our head that our path to success is direct. We're just going to go right there. But many times it isn't direct, and it's okay for it to look like this with many peaks and valleys and obstacles. But if we love what we do and we want to pursue what we're doing, we have the opportunity to chase that dream, make those paths, accept the failure that we encounter once in a while, and still be successful. The other important thing is we have to always reevaluate what we're doing. When we are heading down a path, if it's not taking us in the direction we want to go, it's okay to let that go and redirect, constantly reevaluating what we're doing and ensuring we're doing something that's taking us in the direction we want to go and doing something that we truly love. And you have to love what you do. So this is my desk at home. Out the window is the lake that I live on, that I water ski on all the time. My computer's in front of me that I love. I have my Dre Beats that I listen to my music to while I'm working. And overall, I mean, if you do what you love, it is easy to work on things, and it is easy to have failures and just redirect and work some more on it because you're driving towards something that you really want to accomplish. And so when I think of greatness and defeat in the sport of plastic surgery, there is no defeat. Like I said before, only opportunities to learn and get better. And the reality is most of all, if you want it, go get it. So for all of the young people in this group, the one other thing I want to say is we are frequently told that as clinicians and surgeons, we can't be competitive for extramural funding. I think that is completely wrong. I think I have an unfair advantage in getting funding, because I can see things in a way that a basic scientist might not see them. I can look at something in a novel perspective that hasn't been viewed, by other people in basic science working on the same thing. So I can actually bring a whole new approach to problems that people have been working on for decades. And I might even be able to solve something that really smart people have worked on for decades, but no one with my background had worked on it before. So never let anyone tell you that you can't get research funding and be a successful surgeon and a successful academician. All you need to do is go get it. Thanks.
Phenomenal message, Dr. Soderna. Thank you so much for that incredible talk. And, as Amy mentioned before, really none of our panelists need an introduction, but it feels so wrong to not give you guys the introductions you deserve. But we're going with, you don't need introductions because you're all former chairs of PSRC and incredibly successful in those areas that you love doing, that you've gone out and gotten it. So thank you again, Dr. Soderna. Our next panelist is Dr. Susan McKinnon from Washington University. And she's going to be sharing her thoughts on greatness and defeat in the sport of plastic surgery. Thank you.
Well, thank you all so much. And Paul, I love that talk. And I love talking about failure. That's not how you get where you are, is by failing. It's only success that gets you where we are, but only growth comes from failure. And I have a TED talk on failure, and there's nothing more I like to do than talk about failure in 7 minutes and 58 seconds. So for me, as I'm just learning how to advance, for certain, to me, good things do come from bad things. And here's Steve Johnson, who wrote that terrific book on innovation, where innovation comes from. And here's another one of his books, Everything Bad is Good for You. You'll probably see a very similar theme through this. So when I think about bad to good, I think about the decades I spent studying nerve grafting in the lab and in the clinic, and how that took me through that whole process of pushing nerve autografts and then pushing nerve allografts longer, more, and then failure. And it's interesting for me to look back on this picture. You can see those long nerve allografts, and even now in 2021, you have to black out his eyes. I took this picture because I thought this was a great result. When I looked at his result, I was so proud of the hours that I'd spent in the lab, in the OR, doing those long grafts. And you can see from his face, he's not so impressed. But that great result drove us into research work looking at nerve allotransplantation, the first publication in 1978, and our lab has continued to look at nerve allograft ever since then. We developed models of that. We used it in patients. You can see this long median nerve graft with the allografts. And it was based on this very catchy idea where the Schwann cells would repopulate from both ends of the graft and support the axon growing through the allograft. And this idea is very nice, but it is not true. As you extend the graft length, that whole central section becomes toxic for every cell that's helpful in having nerves regenerate. And we learned that, and you can see here's a patient in 2011 who had horrible neuropathic pain from intercostal neuromas going all the way from the very back. And we use these long nerve allografts now, understanding that nerves actually won't grow as the graft gets longer. And we used it to, rather than move regeneration, stop regeneration. And here he is prone, these bilateral sural nerve fresh allografts with immunosuppression. And indeed, it did get rid of his pain, but now we have other ways to stop regeneration other than these long nerve allografts. So good did come from this failure with allografts, including the acellularized allografts, which we all use with good results at short distances. And also the idea that immunosuppression with FK506 would enhance nerve regeneration. We initially looked at all the details of how much, how long, what dosage, how to administrate it. And we got that nailed down. We used the FK506 in every nerve injury model we had in the lab and consistently had an improvement by 20 to 15% of function. And that still is used now in composite tissue allotransplantation, where a nerve is used. Also from the defeat of our long nerve allograft sojourn, where all these models that we have in the lab to look at nerve regeneration, the microscopy, Dan Hunter being able to do quantifying counts, retrograde labeling, functional assessments, muscle force measurements that we learned from our colleagues at Ann Arbor, and then the transgenics, where now we could use these transgenics to actually evaluate whether the work introduced, even in the early 1900s, people were talking about these nerve transfers. But with the transgenics, you can see the nerve regeneration, and you can see whether or not actually a reverse endoside, a supercharged endoside, will grow into that denervated nerve, and you see that it can. So from the misery of, not misery, we learned a lot from that, but from the failure of doing long nerve allotransplantations, we're not doing that clinically, but we are now doing nerve transfers. And so from that bad came that good. And results now, same upper plexus injury as that first young man, and a much different result, a much more successful result, a great result with nerve transfers. Here's just one example: the median nerve above and the radial nerve above, the median nerve below. That we did one of these transfers this morning, and here you can see a result from median to radial nerve transfer. This was a medical student who was injured, high radial nerve injury, and now is an ENT surgeon after having this medial to radial nerve transfer. Much superior result than what we get with tendon transfers. And then now we're using it for spinal cord, the turbocharged, supercharged nerve transfers, radiculopathy, spasticity, stroke, and even the TMR. I looked at this opportunity today to also talk about lessons learned besides the good and the great. And a key part in my practice is patient selection, clinical judgment, coming out of very detailed physical exam, and then in the last 5 or 7 years, understanding how to interpret an EDX. So I'm going to close with this concept, this pain evaluation, which is so simple. Every patient, every visit tells me how they're feeling that day. I don't have to listen to talk to the patient. I can just see from this where they're at. And when you take a look at this, almost on the same clinic day, 3 different people coming in, one with fairly straightforward, all the VAS scales over to the left, and then others way over to the right, and then this poor gentleman on the far right with everything hurting. If you don't ask the patient to do this, then you could be in for surprises when you're doing something, for example, on the fellow on the far right, a simple operation. And what I've learned from, lessons learned from the great physical therapists that I've worked with, Christine Novak and Lorna Kahn, need to be mentioned. Understanding muscle imbalance, understanding how this muscles around the spine really affect everything that we do as nerve surgeons. This is very powerful. Sensory collapse test is like having a MRI to evaluate nerve pain and nerve compression in my pocket. Costs nothing, it's right there. And I've been working on that, as many of you know, since I was introduced to it in 1991 and then first published in 2005. It is an amazing test. Now, finally, difficult patients, too many questions. Patient asks you too many questions after you have spent really too much time, anatomy books, plastic models of the brachial plexus, a TOS patient who's 16 years old, and after multiple visits, these are the questions I get from the mom with my name spelt wrong, and too many questions, not a good surgical candidate. 1978, in the New England Journal of Medicine, James Groves wrote an article which he called Taking Care of the Hateful Patient. I just call them difficult patients, but he identified these 4 types: entitled demanders, whiny non-compliant, non-whiny non-compliant, and clingers. Earlier in the week, or yesterday, I guess would be earlier in the week, I had one woman who was entitled demanding and whiny non-compliant, and also a clinger. So identifying these patients, I think, is really helpful to just get through your clinic day in a sort of medicalizing these patients that you see all the time. And finally, understanding how to read an EDX. Holly Power, hand fellow a couple of years ago. Okay, now it's 8 minutes, 8 minutes, so I have to stop. 2 more slides. This concept of the fact that loss of nerve function is not linear comes from what I call Tessa Gordon's cliff. And you see you can lose 80% of the innervation. Compensation from the other 20% keeps you up at maximum function. Past 80% loss you lose function. But if you can get them back on that clip, then you can gain that function. And for probably 2 decades, I have been a student from the electrodiagnostic neurologist that lived next door to our clinic, and learned how to interpret all these crazy numbers in order to make them simple, so that I know how to know how many motor neurons are connected, how many nerve fibers are there, and I can model the operation I'm going to offer the patient depending on where they are, depending on understanding that EDX and learning from those neurologists. So that's my quick story of the good, bad, and things I've learned. Thank you.
Thank you, Dr. McKinnon. That's such a great talk. It was just amazing. You have inspired so many of us from medical student, resident attendings, and you continue to inspire us. So thank you so much for spending time with us tonight. Our next panelist, again, requires no introduction. I'd like to introduce Mike Neumeister from SIU Medicine. He's going to talk about his wisdom.
All right. Well, thanks so much. I'm in awe of those previous 2 talks there. So I'm going to change gears a little bit and talk from the clinical arena, specifically what Paul had mentioned about constantly looking at your results and seeing how you're doing. I still wake up in the morning and believe I can make the NHL. And because I don't want defeats, I only want victories. Well, and as a disclosure, by the way, what I'm going to talk about is not articular fractures, because I believe they're different. And I'm not going to talk about these open mutilating fractures, because they're different as well. What I'm going to talk about, though, is something that every one of us sees in our clinic. These hand fractures. And I think immobilizing them to start with is completely wrong, and you should be moving them no matter what they are. And I'll explain why. In my training, and the way I learned it, was that there are certain fractures that are unstable. In fact, nowadays, if you go to one of your attendings, actually go to about 4 or 5 of your attendings and ask them what a stable fracture is. You will get a different definition of what stability is on a fracture. So there's many ways to fix a fracture: open reduction, plate screws, pin fixation, lag screws to tension bands. All of them are wonderful, and it's a wonderful operation. I love operating on the hand. You take a look at this thumb, and almost everyone on this viewing this would say that is an unstable fracture of the thumb. And again, you'd have your own definition of what that is. But I'm going to show you that fractures within the hand, because of the beautiful envelope of soft tissue around it, have the capacity to heal, and things like malunion, although common, dysfunctional malunion is not. Non-union is extremely uncommon. And we all learn certain things in textbooks, which said, a fracture of a certain angulation, that's an indication to operate on this if it stays out of that reduction. And each bone has a different angle of that's been quoted as the time to start to operate. Well, I'm going to show that that's wrong too. We were told that oblique fractures, spiral fractures, are inherently unstable. The intrinsics pull them out of their reduction, and therefore open reduction internal fixation. And it can be really sexy to get this kind of result where you don't see the fracture line at all. Multiple fractures of the hand, always considered unstable. Well, I'm not sure that's true either. So if they're unstable, you need to operate. I'm not sure that's true either. So I had this gal right here. She was a high-end college student playing volleyball, and said, I have this fracture, and they told me I need an operation. My trainer said, make sure you get this fixed so you can get back and play right away. And so I do just that. And she convinces me. I said, it's not really that displaced. But at the end of it, I put 3 lag screws in, and I'm going, man, that is a sexy reduction. I like that. Well, afterwards, she was stiff for about 8 weeks. Eventually, she got back to full range of motion with therapy, but she was 8 weeks out. These days, I get people moving within a few weeks. They're actually doing a lot better than that. So, is the sexy reduction worth it? So here's the horror. Here are the lessons learned. A fracture like this, you can see the proximal phalanx of both the long and the ring finger, somewhat displaced, not so bad on the long finger. The ring finger, you could reduce that, splint it temporarily, but get her moving right away. She happens to be an OR nurse, by the way. two bulky plates put on there, and actually the reduction isn't even maintained. So one pearl, by the way, and one lesson learned, if you're going to open it, you should get a anatomic reduction. Did not get that. She ended up with 17 operations, including 4 different hand centers around the country. Her end result, as a result of multiple tenolysis procedures, and then tendon ruptures, tendon reconstructions, all from fractures that probably did not need to be operated on in the first place. As I look back at this and critically think about it, this was a big mistake. What about this fracture? Minimally displaced and think I can get them moving faster. Well, again, if you operate on these, you better get them anatomically correct, because now they're scissoring, they have a contracture, and they require more surgeries in order to get that back into normal anatomy, then tenolysis, and they're still left with a contracture, but no more scissoring. How many operations does it take for you to wake up and say, I need to learn a lesson? Now, many people have reported on this. Stern looked at his own results. He said 92% complication rate for phalangeal fractures if you operate on them. Now, what procedure in the world do we do that gives a 92% complication rate? 67% of those are stiff. Well, Nick Vetter, who's going to talk next out of his group, said that stiffness, in order to alleviate that, you're going to have to get them moving. And non-operative treatment, those bones can actually handle a fair amount of malalignment, not necessarily scissoring, but malalignment. And further, that if you do get some stiff fingers and you operate on them, most of those folks do not regain the normal motion. Well, if that's the case, most of the fractures you're going to see in your office do not need surgery. Now, what do? Tell the resident, don't look at the x-ray. If they can do this and they can do that, does it really matter that they have 2 metacarpal fractures that are spiral that may be an indication to operate on those? Probably not, because if my goal is to create a normal functioning hand with normal range of motion, to operate, I'm only going to do harm. Similarly, we talk about boxers' fractures and the amount of angulation. Don't look at the x-ray. So if they can make a fist and they can straighten their hand, do you actually need to operate on them? Probably not. Now, first thing, here are my tenets of the management of these. If it involves the joint itself, restore the congruity and move them early. If it is not, first of all, don't pay attention to the x-ray. Don't pay, or you document that there's foreshortening of the metacarpal, loss of metacarpal head, dorsal prominence, maybe hump deformities, minor extensor lags, but you don't necessarily need to treat those. Mohammed El-Katan taught us most of those extensor lags go away. Angulation. Sure, they have this hump deformity there, but if they can straighten their hand and have normal function, I'm a plastic surgeon, so I believe in cosmetic surgery. That, in my mind, would be a cosmetic surgery to correct that. You assess the range of motion, and if it's normal, allow them to continue to move without surgery. So something like this, normal range of motion, they have a minimally displaced, just like that athlete I showed you. I didn't need to operate on that person. Get them moving right away. Now, they are amenable to closed reduction. Maintaining that reduction doesn't necessarily mean that you have to do surgery if it falls out of reduction. Here's that thumb that I mentioned before, that I showed before. That's a huge amount of displacement. Surely you're going to operate on that one. Well, what if I didn't? This is an x-ray technologist who actually said, I don't want surgery on this. And without doing anything, she regained her motion, and that bone goes on to heal and remodel. The vascular envelope around these bones is enormous, and motion is not a contraindication to healing. Scissoring requires correction. You got to attempt to do that. Now, if you can do that without surgery, great. But obviously, if you can't, that requires an operation. Get edema control so that they can move. If that proximal phalanx is fractured in their edematous, get them moving, buddy tape it. You don't necessarily need to operate on it though. Provide protective thermoplast orthosis for nighttime use, but take them out of it during the day. And they can move it as many times a day as they want. And what I tell them, if it hurts, don't do it. If it doesn't hurt, you can carry on your activities. And then I do bring them back a week later just to assess that they are not scissoring. There is no malalignment. And I might even bring them back 2 weeks after that. The normal cascade is what I'm looking for. Take a look at the little finger in this picture. Little finger, before you make a full composite flexion, is always scissoring over. Don't be fooled in the emergency room by saying that Boxer's fracture is scissoring. I can't tell you how many times I've heard that, but I've never seen scissoring of a Boxer's fracture. Angulation, I'm not worried about that. Multiple fractures, it is not an unstable hand. You take this lady here with 2 metacarpal fractures. In fact, the ring finger metacarpal is almost completely displaced. Surely you got to fix that. But what if she could do this when she comes into the office? And then you take an x-ray a couple of months later, and what if she's looking like this? She remodeled, you keep her moving. So what I've learned is be critical. The sexy operation, maybe not what you need to do to these patients to get the best result. Thanks so much.
Awesome. Thank you, Mike. It's so great. And I mean, I cringe seeing your x-rays, but I mean, it's just masterful and great advice. So thank you. And we're going to finish off with our last speaker, again, who needs no introduction, Dr. Nicholas Fetter. Why don't you give us your thoughts on the greatness and defeat in the sport of plastic surgery?
Thanks very much, Amy. I'm really excited to be on this panel. This is, can everybody hear me?
You sound great.
Yeah, okay. 2 things. One, I continue to think that the Plastic Surgery Research Council is the single most important organization in all of plastic surgery because it is the crucible of innovation, and innovation is what defines the specialty of plastic surgery, and without it, we're dead. So I love the Research Council. And I also want to shout out to Susan McKinnon, who we've never worked together clinically throughout my entire career, but Susan has been a very important leadership mentor to me for my entire career, beginning back with the Research Council, then the Hand Association, and most recently the American Association of Plastic Surgeons. So thank you, Susan. So greatness and defeat, like the others, I have lots of defeats. I was the Research Council chair in 2000, so I've been in practice for 31 years, and so I have plenty of defeats. So learning from our turds. This is me, University of Washington, Seattle, Harborview Medical Center, the only level 1 trauma center for 5 states and 11 million people, and part of a combined orthopedic plastic surgery hand service for the last 31 years. So we all love sharing our triumphs. Boeing engineer with a 5-digit amputation and being able to put them all back on, restore his hand function, restore his life. That's great. We've got lots of those, but really we learn more from our turds. By sharing, let's see, by sharing, we learn from our turds. Hopefully others can avoid them. Learning from your mistakes and sharing what you've learned with your colleagues and trainees is key to improving patient care and reducing errors. So what do I mean by a turd? Well, it comes from the American Alpine Workshop in Plastic Surgery. This is our last overseas meeting in Zermatt, Switzerland that I organized as the chair along with Betsy All Findley and Phil Blondeel. And we go skiing during the day, and then in the afternoon we give short 3-minute talks, and it's different every day. And the highlight of the meeting is the turd day. And this is the turd, the trophy for unredeeming reconstructive daring do, one of the most coveted awards in all of plastic surgery. And that's reportedly Bill Little's turd at the bottom, but you can see some pretty famous people here at Fouad Nahi, et cetera. And if you look closely, let's see, there's Peter Nelligan, Hector Frank, and Mike Neumeister, Paul Sederna, and Nick Vetter. So the turd is well represented on this panel today. How do you lose or win the turd? Poor judgment, poor technique, poor management of the complication, crappy photos in the patient worse than before you started with them. So here's some past winners of the turd award, and you can see there, Bill Blondeel, Fouad Nahi, Grotting, Sederna, Neumeister, Pribez. So it's a lot of fun. And last year, Beatriz Beringer, the first woman, won it. She's from Madrid and the past president of Europe. So we're excited about that too. So errors and complications, don't hide them, embrace them, learn from them. What could I have done differently? What should I do next time? And most importantly, teach from them. And that's what we're doing here today. So I'll start with a case, one of my TURD Award winners, the 33-year-old male, rollover MVC, hand out the window, dorsal hand avulsion, MCP's gone, drinks a quart a day, comes in with a 3 times legal alcohol level, does benzos too, and whoop, wow, just a flesh wound there. And missing all of his MCPs all the way across. So we came up with this fancy idea that we'll do K-wires and an antibiotic impregnated methacrylate spacer sandwich as a temporary spacer, and then plan for later bone graft, and then cover it all with a giant groin flap. And there's the K-wires in there, there's the methyl methacrylate. You can see trouble looming, put it in a giant groin flap. And of course, he goes through alcohol withdrawal, requiring everything in the world, dehisced the flap 3 times, repaired at the bedside, 3 weeks in the ICU, and what do you get in the end? Pus. So open it up, IND it, clean it all out. Looks pretty good at first, but oh no, trouble again. So 3 more INDs, flap advancement procedures, finally close it, finally get it closed. And here we're going to plan to go back in and do the bone grafting. So we open it up, clean out the bone, harvest some giant iliac crest bone graft, plates and screws. X-ray looks really pretty. Comes back at 2 weeks for suture removal, and oh, it'll probably be okay. No. So one of my favorite paintings, Edvard Munch's The Scream. Strep viridans, actinomyces, candida, 3 attempts at IND closure, IV antibiotics, and all of that bone graft in the bucket. 2 more INDs, 10 months and 10 operations after injury. And this is what we have. What is it? A scrotum? A butt? It's a hand, of course, and it still has a draining sinus, but fortunately the function is absolutely awesome. There, you can see it there. So he wound up with a $250,000 back scratcher. And then at the very last visit, doc, what can you do anything to make my hand not look like a butt? So what did I learn? Well, we definitely should have done a single stage free flap instead of the groin flap. Repeated dehiscences killed the plan. Foreign body spacer was completely unnecessary, a really bad idea. Would have been better to do nothing, just soft tissue arthroplasty. So another case, iatrogenic nerve injury. I remember being on an ASPS panel with Susan many years ago, and she started out by asking everybody in the audience to raise your hand if you've never had a nerve injury. And then she said, well, you're either lying or you haven't been in practice very long. And I think that's definitely true. So here's my 1,242nd endoscopic carpal tunnel release. Did it with the chief resident. I assisted, thin hand, 1 pass, surgery went smoothly, 2 weeks post-op, dense numbness of the 4th common digital nerve. And there's the scream again. Immediately explored it, found complete transection of the common digital nerve, repaired it. And you look at it, how on earth did we wind up over there? I mean, I don't understand that. So go to the anatomy lab and look and see if you rotate the blade ulnarly, boom, that's how you do it. So saw the patient weekly, monthly, for a year, openly shared my agony and pain, which was plain and clear. At 1 year, still had 12 millimeter 2-point discrimination and a little bit tingly. Hasn't sued. 5 years later, came back to see me for an elective LRTI. At that point, she had a normal 2-point discrimination and no longer tingly, and is one of my favorite patients that I've continued to operate on. So lessons from that: never rotate the blade ulnarly. The ulnar nerve is right there. Never use palmar counter pressure. Err on engaging the blade proximal to the distal edge of the ligament. And you can always get more with a second pass. Make that patient the most important patient in your practice. And now I've done over 2,500, including having my chief resident do myself. So if it happens, recognize it and address it early. If you think it could have happened, it did. If you think it's probably okay, it isn't, and repair it as soon as you recognize it. So why haven't I been sued in 31 years? I don't know. It still could happen. I am quick to openly share my personal pain and agony with patients and family. Make them the most important patient in my practice, and hopefully allow them to understand that I'm a caring and compassionate human being trying to do the best that I can. So don't hide them, embrace them, learn from them. What could I have done differently? what should I do next time? And most importantly, teach from them. And rather than have one more turd, I'm going to share my mega career turd when it comes to research. When I started out in the lab as an NIH-funded trauma research fellow in 1986, we had this hypothesis that ischemia would produce tissue injury, that with reperfusion, you'd get this white cell mediated inflammation and reperfusion injury. And if you could block white cell adhesion, you could potentially prevent reperfusion injury. And so we had a monoclonal antibody that bound to the adhesion receptor on neutrophils and would very effective at preventing neutrophil endothelial adhesion. We did it in a ischemic rabbit ear ischemia reperfusion model and was really effective at preventing reperfusion injury. And histologically, you can see the neutrophil-mediated vascular injury with white cells and red cells out in the tissue that was completely prevented by blocking adhesion. It was very effective at improving random flap survival. In a rabbit shock model, it dramatically improved survival. And in a non-lethal primate shock resuscitation model, it dramatically reduced resuscitation volume. So we thought maybe we had the magic bullet for reperfusion injury. So a local biotech company, ICOS, developed an anti-CD11, CD18 monoclonal antibody for clinical use in trauma-induced hemorrhagic shock. And we knew from epidemiologic studies, if you took traumatic shock patients who had a blood pressure less than 90, they had a 50% mortality rate. So we thought this is the perfect target population. And we got the first ever waiver of informed consent, both from the UW and the FDA, to save dying patients. And these are the patients we were after, massive transfusion trauma patients. And we thought, well, here it was in the Seattle Times, new trauma drug is saving lives, we hoped. But the results of the phase 2 multi-center study were not so good. There was a slight improvement in mortality, but our death rate was only 10% and was supposed to be 50%. So of course, we're not going to find any difference there. So we found no treatment effect on crystalloid, ICU stay, ventilator, or mortality. So from 88 to 2003, we went through the cellular and molecular biology of adhesion, animal models, phase 1 trial, multi-center phase 2 trial with waiver and informed consent, 15 years, and we've won. So new trauma drug, not saving lives. Why? Well, it was perverse incentives. So waiver of informed consent, enroll dying patients, 50% expected mortality. Centers were paid $12,000 per enrolled patient, and they only needed one reading of less than 90. Well, guess what? They quickly found a lot of readings less than 90 and had patients sitting up in bed to sign their consents, and that's not the population we were after. So other anti-adhesions trials also fell flat on their face, MI, stroke, MS, and no, there are no magic bullets. So reperfusion injury is now the pariah of the drug industry. Do I think it works? Yes. Will it ever see the light of day? No, because it's lost the industry $50 million. So beware of perverse incentives. The wrong inclusion-exclusion criteria will kill your trial. But if you fail, and this is the most important thing, even if you fail big, don't bail. I bailed. I did not renew my R01 grant, and it's the greatest regret in my entire career. So there is always another good question to investigate. Never give up. Thank you.
Wow, another phenomenal talk by our panel. And thank you so much, Dr. Vetter. That was incredible and highly entertaining as well. But I hope everyone took notes, because the collective wisdom and transparency and humility shared on this panel from 4 incredibly successful former chairs of the PSRC is unlike anything you will find anywhere. And I think that really speaks to our specialty and to this society as a whole. So thank you to all of our panelists. And now we want to open up for questions and discussion.
Well, of course, I was trying to be quiet. Like, that was what I've been this whole night. So I want to actually ask the panelists to ask each other. So you all have been leading the way, both in a research career as well as in your clinical acumens. So when you think about the defeat in English, do you guys consider, like, do you work together now? And I know, Nick, you talked about with Susan being a huge influencer and supporter. And I know Paul and Mike, you guys go back and forth. Like, do you call each other on your failures? Do you help each other through your failures to get to the next level? Do you have other ways of making a failure into a success with using the people of this great organization?
One thing I can chime in there, Amy, thanks for the question. I think what's important is the camaraderie that you have and the openness that you have about that. I've been to many conferences and such when I've actually heard Susan mention that, it's not going to be a straight line up to where I am, from where I was to where I am now. There will be ups and downs. Paul just showed that graph too. And Nick, as he explained, I mean, you're going to keep reviewing your own results and then make them better. We talk amongst ourselves all the time. Paul and I chat not infrequently, and cases we're doing, or whether they're actually, we share triumphs and laugh about it. We also share those turds, as Nick called them. But that camaraderie, and everyone should have that ability to do that, is so important, that dialogue. It actually keeps you humble, but it also keeps you going, I think.
Yeah, so I would agree with everything that Mike said. One of my favorite meetings of the year is the one meeting Nick was talking about, the Alpine Workshop, and we spend a whole day, and all these famous people from around the world show these horrifying cases, just horrifying cases, and they are these people that do incredible things every single day, and you realize that actually everyone's human, and the only way any of us get any better is if we have a mistake, recognizing it was a mistake, or it was an error, or it wasn't perfect, understanding why that happened and using that to get better. And so we have to be able to reflect ourselves and be aware ourselves of what we're doing. But then we also have to have the wherewithal to be able to reach out to our friends and colleagues and everything and share those challenges with them, so we can get better, and ask them, what would you do in this situation? How would you manage that? How would you go about that? And so it's so important. And I will tell you, Nick and Mike and I share a ton of clinical cases together. Susan and I have shared a bunch of research things together, and I've been on grants together. She's one of my research heroes. And if I can just keep, doing what she has done and influencing so many people and having such an impact on the field, that would be incredible. And so, but I think more than anything, sharing victories is easy. Sharing failures is hard, but that's where the learning comes in.
Yeah. I will often call Susan with my most challenging nerve cases, and she's always been really, really helpful. And I speak with all you guys, especially about difficult leadership decisions. And another person I lean on all the time is Jim Chang. So what I miss right now is being able to get together with my friends from around the country and around the world, because that's where those relationships are made. They're not made on Zoom. So I can't wait to get together again.
Susan, thoughts? I think you're still muted. I love that phrase. I just keep rolling with
And no,
it.
and that takes a bit of time to unmute, and you're trying, and they're telling you unmute. I'm trying. This was a great panel, and how important for us to have this opportunity to discuss the other side of the coin, which we don't discuss. It was Amy, I think you were at that meeting when the nerve meeting, Doug Ross in London was talking about, he and I were talking about vulnerability and how important it is to our residents to show our own vulnerability, because it's a hard job we have. It's isolating. It's very hard for the residents, and just having a failure is so isolating and shameful, and you can't talk about it. I love so I think we should be talking more about vulnerability, and Nick, I liked I liked your points where you were talking about how it is you haven't been sued in 31 years. So I had one woman, I don't even remember her name, who tried to sue me, but it didn't go anywhere. Touch wood, right? But there's got to be strategies for that. And I have my own strategies. I apologize profusely. I say, have you heard that I'm so sorry? And they say, no, I didn't hear you say that. And I said, like, to take the energy down and oh my gosh, leaving our colleagues with a complication where and then the lawyers say, don't talk about it to anybody. We really should be doing more about that, especially now with all there was burnout before 2020, and now the mental anxiety, exhaustion, psychology. Andrew Yee and I just PubMed, COVID, psychological distress, general people and healthcare people. I'm talking about this later in the week, Amy, with your group, with post-traumatic stress disorder, depression, and it is like through the roof. So I think we really have to think about talking about this on the curriculum, getting together, maybe even just a survey of the tips you have, how you manage a patient when you have a complication, because just like you said, you know, if you're operating on nerves, you are going to screw up a nerve. And when you screw that up, you remember May of 2018, and it took till May of 2019 for those intrinsics to come back. And like every single day I suffer. We suffer enough with what we do, so we can't be our own worst enemies. So anyway, this was just lovely, a lovely way to spend the evening. Thank you all for organizing it.
And again, just a shout out to the Research Council. This organization is the genesis of our specialty. So I'm just so proud to be part of it.
Ditto.
Totally agree.
Proud of all of you. Thanks for being a part of it.
Thank you, everyone, for your time and for being here. I just want to close out our session. I want to thank you all so much for participating. And I also want to thank my co-moderators, Amy and Allison. It was really fun to have this, to actually be able to come together, even though it's virtual. It was really awesome. Also want to thank our sponsor, Synovus MCA, for making this second night of the pentathlon a success. And I wanted to add, I see Justine has joined. I wanted to add a little plug in there that we're adding an extra element to the pentathlon program this week, and also to appeal to PSRC's social media following. Dr. Justine Lee and members of the Research Council's Tech Committee have organized an Instagram live session for each night of the pentathlon program. The Instagram live session will be a play-by-play of each night's programming, and it'll be just like, you know, sports commentary during a game. And so we are calling this group the Closers, which is a really cool name. And so the Instagram live session will take place immediately following this session. And the Closers may comment on the live panel and or recap highlights from this evening's program. So be sure to check them out. And finally, I want to remember or to remind everyone to join us for subsequent events for the pentathlon. So tomorrow will be craniofacial and congenital anomalies. The next day, Thursday, will be transplant and microsurgery. And then on Friday, it'll be breast, aesthetic, and gender affirmation. So with that, I thank you all once again, and good night.
Thanks, everyone.
Great job.
Thank you. See you tomorrow.
Thanks again.
Cheers.
Bye. Great job, guys.
Thank you.